Dr. Shahina?
Yes.
Yes, Dr. Raj Lakshmi?
Yes, sir.
And Dr. Nidhi?
Yes, sir.
Okay. So we'll be starting the award paper session. So Dr. Goel, Dr. Sandeep Goel is going to tell you further about it. Just a brief information for all of you that you will get 12 minutes to present your paper, and there are 3 minutes for discussion. And you'll be marked on where you are presenting your paper, time limits which you maintain, and the question and answer which you answer. So with this brief introduction, now I hand over to Dr. Sandeep Goel to start the proceeding. I think, Dr. Goel, everybody from your side is there? Dr. Sandeep? Yeah.
Yes, sir.
So everybody from your side is there? So you're ready with the...
So me and Manisha has joined, and let me check about Dr. Midda. I think he is not here. Let me call him.
Okay, you can take 2 minutes. Yeah.
ग्रोवर सर गुड मॉर्निंग.
वेरी गुड मॉर्निंग सर.
कैसे हो सर?
मैं ठीक हूँ सर.
Dr. Midda will join physically.
Okay, sir. Okay,
He's
sir.
on the way.
Okay, sir. So, sir, it's up to you now to inform the presenters about what is the sequence, who is the first, second, third presenter, and how they have to go about. It's all yours, sir.
Yeah, thank you, sir. Theory papers have already been marked, and now there are 40 marks left, and 20 marks are style, clarity, compactness of expression and presentation. 10 marks are use of audio visual aids, appropriateness, quality, visibility, comprehensibility, and 10 marks are response to the points raised in the discussion. And first paper is depression in PMDD. Second paper is neurocognitive disorder 1, and third paper is psychosis, first episode psychosis. Shall we start, sir?
Yes, please. Please start.
Dr. Midda will join in a minute or two.
ठीक है. By that time, I think we can start. No problem, sir.
Yes, sir.
Should I share my
Kindly share your screen. Yes, it's visible. Kindly start the slideshow mode.
So there seems to be a so are the slides moving?
Yes, they are visible. Kindly start.
Sir, are the slides moving now?
Yes.
निधि visible है just
Good morning, everyone. The aim of my presentation was to assess prevalence of premenstrual dysphoric disorder and its correlates in females of reproductive age group with the diagnosis of recurrent depressive disorder. So as per DSM, in most of the menstrual cycle during the past year, out of which at least one symptom should be one of the four. That includes affective lability, irritability, depressed mood, and anxiety. And rest of the four symptoms from loss of interest, fatigue, feeling emotionally overwhelmed, and physical symptoms for our diagnosis of premenstrual dysphoric disorder. The duration of symptoms should be starting 1 week prior to the onset of menstruation, and they must improve within a few days after the menstruation onset. Various studies have looked at the prevalence of premenstrual dysphoric disorder. It is found to be around 2 to 8% in women of reproductive age group. A meta-analysis which included 25 studies with more than 8,000 participants found the prevalence to be 8% in the reproductive age group. Various studies have seen higher level of co-occurrence of premenstrual dysphoric disorder in patients with depression. A study reported premenstrual exacerbation of depressive symptoms in 64% of the women with depressive disorder. And another study showed that there is increase in admission rate by up to 50% due to premenstrual exacerbation of symptoms. And there is also high frequency of suicide attempts. Few studies from India have also examined the prevalence rate of premenstrual dysphoric disorder, and it is found to be in the range.
Judges, what Sandeep told me on the judge.
It is found to be in the range of 3.7 to 39%. The various limitations of Indian studies include that a validated tool was not used in many of the studies, and the study population was limited to adolescent females. The clinical setting was not used for the study, and studies did not assess the association of premenstrual dysphoria with depression. The lacunae of various literature includes that despite the association of depressive disorder with premenstrual dysphoria, a limited number of studies have looked for coexistence of these two different disorders. And limited number of studies have assessed impact of presence of premenstrual dysphoria on symptom profile, severity of depressive disorder, and quality of life and morbidity. From India, there is no available data for co-occurrence of these two disorders. So my study aims to assess prevalence of premenstrual dysphoria in reproductive age group female with the diagnosis of recurrent depressive disorder. Objectives of my study were also to evaluate socio-demographic and clinical profile associated with presence of PMDD in reproductive age group females, and to evaluate impact of PMDD on symptom profile, severity of depression, association with features of used a cross-sectional study design and used purposive sampling method. The sample was selected from a tertiary care center, and study sample included 100 participants. Females with the diagnosis of recurrent depressive disorder as per DSM-5 assessed by Mini 7.02 version were included. Those who were between the age group of 18 to 45, those who were able to read Hindi or English and provide written informed consent were included in the study. And patients who had achieved menopause or had hysterectomy or bilateral oophorectomy, those with intellectual disability, cognitive impairment, or organic brain syndrome, presence of acute debilitating physical illness, comorbid substance dependence, urinary tract infection, history of irregular menstrual cycles, or using oral contraceptive in the last 1 year were excluded from the present study. The instruments that we used included premenstrual screening tool for the evaluation of premenstrual dysphoric disorder, which is based on DSM-5 criteria, Beck depression inventory for assessment of depression, and inventory of statement about self-injury for self-injurious behavior. Coming to the results of my study, premenstrual dysphoric disorder was found to be present in 20% of the study participants. And the most frequently found symptoms were reported to be anger and irritability, anxiety, symptoms such as breast tenderness or swelling, depressive mood, fearfulness or feeling sad, easy fatigability, and reduced interest in work. The prevalence in the present study is within the reported range of the existing literature. When individual items of premenstrual screening tool were compared between those with presence of PMDD and those without, a significant difference in the frequency was noticed on the items of tearfulness, feeling suddenly sad, depressive mood, decreased interest in various activities, difficulty in concentrating, easy fatigability, feeling overwhelmed, physical symptoms, hopelessness, self-depreciating thoughts, mood swings, specific food craving, and increased sensitivity to rejection. In criteria B, significant difference was noticed on interference with work and relations with the family. Coming to socio-demographic profile, mean age of the study participants was 34.8 years. Most of the patients were married, with mean duration of marriage being 13.4 years. Mean years of education 11.7 years. Most of the participants were unemployed, belonging to a lower middle socioeconomic status. They were Hindu by religion, belonging to nuclear family and urban background. When we compared those with presence of PMDD to those without, significant difference was noted on the age at the time of assessment, marital status, and duration of marriage. This finding is comparable to previous study in our center and in other centers of the India. Coming to clinical profile, mean duration of illness was 75.3 months, with duration of current episode being 2.3 months. The significant difference was noted on the severity of current episode, with those without PMDD had more mild episode than those with. Coming to depressive symptoms, which was assessed using Beck depression, of various symptoms were compared. Only significant difference noted was on the item of loss of energy, which was significantly higher for those without PMDD. And when a mean and standard deviation were compared, the mean total score on VDI for the whole group was 27.6. Significant difference was noted on the item of loss of pleasure, crying, indecisiveness, and weight loss. None of the studies have specifically looked at impact of premenstrual dysphoric disorder, so that it is not possible to compare these findings with the existing literature. Coming to self-injurious behavior, which was assessed using DSM-5 criteria for non-suicidal self-injury, 19% of the participants reported non-suicidal self-injury, and when clinical rated severity was assessed, significant difference was found on the moderate severity, which was higher for those with PMDD. Finding is in the reported range, which is 3.85 to 17.3% for young females. Coming to reason and statements about self-injurious behavior, significant difference was noted on the item of affect regulation, with it being higher for those with premenstrual dysphoric disorder. Previous studies which involved patients of premenstrual dysphoria have not assessed the prevalence of NSSI, so it is not possible to compare this finding. The implication of this finding is that findings should be considered preliminary and there is a need to replicate the finding. It is suggestive that patients with depression and comorbid premenstrual dysphoria should be regularly evaluated and monitored for suicidal and non-suicidal behavior. Coming to limitations of my study, it was conducted at a tertiary care center, therefore cannot be generalized to other treatment settings. It is a cross-sectional study with small sample size, and it did not include a comparative healthy control group. Various factors like socio-cultural aspect, religious value, association of assessment with PMDD or menstrual cycle, sexual dysfunction, presence of marital discord, impact of treatment, and knowledge about menstrual cycles were not taken into account. And assessment was only limited to instruments. Coming to future direction, future studies are needed to better understand the association between premenstrual dysphoria and depression from a large study sample size at a different point of time. And a study which includes both qualitative as well as quantitative measures should be considered in a community setting. A comparative healthy control and population with different psychiatric illness is also required in future to understand the exact relationship. Thank you.
Hi, and good morning. Any specific reasons to exclude people, the females who are taking oral contraceptives?
Sir, we had suspected that oral contraceptive pills might also cause some sort of mood symptoms, so that might be a confounding factor in the findings of the study.
Any questions from online judges?
We have no questions.
Okay. We can move on to next session, next paper.
Thank you, sir. Good morning to all. Shall I start, sir?
Yes, please.
Good morning to all. The topic of my study is an extent of stigma, and it correlates among the caregiver of patient with major neurocognitive disorder. Dementia is characteristic by a progressive loss of memory and other mental faculties such as language, judgment, and planning. Families and caregivers.
Aina, your slide not visible.
Yes.
Aina, slide not visible.
Our slides are visible, sir?
Yes.
Yes, Krishna.
Visible.
Dementia is characterized by a progressive loss of memory and other mental faculties such as language, judgment, and planning. Families of or the caregiver of dementia face many problems, including being afraid to bring the memory loss issues to the attention of the person with dementia. Symptoms such as agitation and incontinence, inappropriate clothing can be embarrassing to the family member. Among the various negative consequences for the caregiver, family stigma damage the identity of the family members since they are discriminated by others despite having normal characteristics. Stigma is a potential barrier to care and support that are manifested in such behaviors such as excluding the person with the dementia in healthcare decision or the shunning of family members of the person with dementia. The negative consequences of the caregiver stigma, it acts as a barrier to carer, utilization of community services, and obtain the support from family and friends. It increases the caregiver burden, depression, and decrease the quality of life, social isolation, and impose an excessive physical workload and frustration. Approximately 70 studies evaluate the stigma related to dementia, and majority of the studies on the lay publics, and 7 studies addresses the stigma belief in healthcare professionals. Approximately 5 studies addresses the stigma among the caregiver of or family member of person with dementia. The lacuna in current research is that there is a few research or the limited number of studies have evaluated the extent of stigma and its correlates among the caregiver of patient with dementia, and no data available from the developing countries like India. The main aim and objectives of the study is to evaluate the extent of stigma and its correlates among the caregiver of patient with major neurocognitive disorder. It is a cross-sectional study, and the sample population obtained from the patient population attending the outpatient service of the Department of Psychiatry at PUNJAB Chandigarh. And we include around 100 patients who are diagnosed with a major neurocognitive disorder and their primary caregiver. It is a purposive sampling technique was used. The selection, the inclusion criteria for the patient are the diagnosis of the major neurocognitive disorder as per DSM-5 criteria. It includes the either genders, and the duration of major neurocognitive disorder is for at least 12 months. And we excluded a patient having an intellectual disability and acute debilitating physical illness and the absence of the family caregiver. And the selection criteria for the caregiver is that the caregiver must be a family member of the patient, satisfying the definition of the primary caregiver. It is of an either gender, living with the patient for at least 12 months, and they themselves are free from any diagnosis psychiatric morbidities. And the exclusion criteria for the caregiver is the presence of an intellectual disability, active substances dependence other than nicotine, and any other psychiatric disorder, and the chronic physical illness. And if they are not living with the patient, and if they are not involved in the care of the patient. If more than one caregiver fulfill the selection criteria, then the caregiver spending more time with the patient was preferentially recruited. And we assess the patient on the socio-demographic and clinical profiles, clinical dementia rating scale, and neuropsychiatric inventory. And we assess the caregiver on socio-demographic and clinical profiles and the caregiver of people with mental illness. Now, result on a socio-demographic profile, mean age of an patient is 72, and most of the patient were male, and they are married, and most of them were unemployed, belongs to non-nuclear family, and they belongs to a urban locality. And on caregiver, the mean age is around 51, and they are mostly male and married, employed, and they belongs to a non-nuclear family of an urban locality. When we compare our study with the previous study reported from India, we found that the socio-demographic is almost similar. And on the clinical profile, majority of the patient were diagnosed with Alzheimer's disease, followed by the vascular dementia and frontotemporal dementia. And the age of onset in most of the patients were around 69 to 70, and around 66% of the patients were associated with a physical illness. Most common is hypertension, followed by diabetes mellitus. And around 19% of the patient had a comorbid psychiatric illness. Around 99% of the patient has a depressive disorder, 4% had a bipolar affective disorder, and 2% had a psychotic illness and anxiety disorder, and 1% has a recurrent depressive disorder and obsessive compulsive disorder. When we compare our study with the previous studies, the result were inconsistent. The reason for this inconsistent may be the study participants were from the different treatment setting, and they do not look specifically for the physical comorbidities and psychiatric comorbidities. In our patient, all of the patients were on the cognitive enhancer, and around 82% of the patients were on donepezil, 40% on memantine, and 22% getting combination of donepezil and memantine, and 54% were on the antipsychotics. The most common antipsychotic used is quetiapine, followed by olanzapine. A similar line to that of the previous study conducted in India, and it stated that the donepezil is the most frequently prescribed drugs and quetiapine most common for behavioral and psychological symptoms. When we rate the patient on the clinical dementia rating scale for the severity, most of the patients were lying in the moderate severity on various variables like memory, orientation, judgment and problem solving, community affairs, homes and hobbies, and personal cares. Similar to that of the previous studies across the world. and the prevalence of the behavioral and psychological symptoms. This table shows that most common behavioral and psychological symptoms were anxiety and irritability, followed by abnormal nighttime behavior. And there is a change in appetite or eating behavior and presence of an agitation and aggression. And the findings in our study is similar to that of the previous study. And when we look for the stigma among the caregiver, the overall score on the stigma scale is around 49.5%. And when we compare our study with the previous studies, there is a shows a difference that may be due to the use of different scale to assess the stigma. But the hierarchy of level of stigma is almost similar to that seen in the chronic psychiatric illness like schizophrenia or the bipolar disorder. Now, the association of the stigma with the socio-demographic and the clinical profile, no significant correlation between various domain of the stigma and the total stigma score with the patient's socio-demographic and clinical variables. In the previous, some of the previous studies had showed that the gender of the caregiver, younger age group, and the children of the people with dementia report a higher level of stigma, and the finding of the present study did not support it the same, and lack of significant correlation could be due to the cultural factors. The association of the stigma with the severity of dementia on clinical dementia rating scale, our study shows a significant correlation was found between the home and hobbies domains of the clinical dementia rating scale and the affective domains of caregiver of people with mental illness. And the present study findings support the findings of the previous studies. The association of the stigma with the behavioral and psychological symptom severity, it shows that higher severity of delusion, agitation, aggression, disinhibition were associated with higher caregiver stigma, and the symptoms of apathy, apparent motor behavior had a significant associations with the affective domains of stigma. Higher level of caregiver distress was associated with higher level of stigma in all the domains. And the finding of the present studies are supported by the previous studies, and it can be said that adequate management of behavioral and psychological symptoms by non-pharmacological and pharmacological measures can help to reduce the stigma experienced by the caregiver of people with dementia. Limitation in our study is that it is a cross-sectional study, small sample size was used, and it is a purposive sampling, and the focus on the caregiver attending the outpatient at the tertiary care center, and we need for our longitudinal studies, and in our studies the assessment was limited to only scales, so difficult to catch all the aspect of stigma. Other limitation includes impact of the treatment, side effect of the medication, non-pharmacological intervention, self-efficacy, self-esteem, previous experience with the patient with dementia, cultural aspect about the dementia, experience with the clinician. A high level need for the future studies based on the longitudinal study design, including a large sample size involving the caregiver at various caregiving stages, will be more informative, and carrying out the qualitative research can provide more information about the different aspect of stigma. Thank you.
Thank you, Dr. Shahina, for completing in time.
Yes, sir. Thank you.
Yeah, good morning. This study, in your study, you've not found any difference between urban and rural, the stigma level and difference in urban and rural?
Sir, there is a difference in stigma level of in urban and rural population, and we found that among the urban areas, there among the rural areas, there is more stigma as compared to the urban areas.
So it's a significant finding. You should have quoted, because we are looking for stigma, right? the major part of the study was covering other things other than stigma. I would have liked you to focus more on the stigma part. One. The other is, since all of your patients were on treatment, in one of your conclusions, you said that that if you treat those patients, the stigma reduces. But how can you conclude that when all of your patients are on treatment? So how is that conclusion been made? You are treating, in your study, you included only people who are on treatment. So none of those patients were drug naive, right? So how can you conclude that upon giving them some sort of treatment, or when they're better, the symptoms are improved, then they are showing improvement, the stigma is less?
Sir, we included the patient. Some of the patients are on the treatment, and some of the patients were not on the treatment. But sir, the stigma were more in the patient who had more the behavioral symptoms, sir. And
I think we can conclude this session. Thank you so much, Dr. Green.
thank you.
I request participants to please state their name and topic clearly, not to rush in the first slide.
Good morning, everyone. Shall I proceed?
Yes.
Thank you. Is the slide visible?
Yes.
Thank you. The topic of my presentation is impact and discrimination on psychological recovery in patients with first episode psychosis. First, coming to definition of first episode psychosis, it is defined as individuals early in the course of a psychotic illness or treatment, rather than individuals who are truly in the midst of a first episode of illness. Consensus definition is based on duration illness criteria of 5 years. There are various issues which are related with first episode psychosis, like psychopathology and functioning, social support and quality of life, stigma, insight, and psychological recovery. When recovery is defined as a process, it is defined as a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills, and roles. It is a way of living a satisfying, hopeful, and contributing life, even with limitations caused by illness. It involves development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. Remission from symptoms is not equal to psychological recovery. A patient can have psychological recovery even in the presence of symptoms. Recovery is about building a meaningful and satisfying life as defined by the person themselves, whether or not there are ongoing or recurring symptoms or problems. There is debate going on to view recovery as a process or as an outcome. When it is defined as an outcome, it refers to a measurable endpoint, often defined by criteria such as being symptom-free, working or going to school for a specified length of time, socializing with peers during the week, or living independently in the community. A 2-year period in which the person is functioning within normal limits in the domain of symptomatology, participating in work or school, living independently, and maintaining social relationship is taken as outcome for recovery. Data from India shows that there are few studies from India which has attempted to study psychological recovery in schizophrenia. One study evaluated the relationship of disability and symptomatology with psychological recovery in schizophrenia by using the stages of recovery instrument scale. Second study from Chennai studied the consumer perspective of recovery. Some of the studies from our center, like Singla et al. In 2015, evaluated psychological recovery in patients with schizophrenia, and Grover et al. 2016 for validation of Hindi version of stages of recovery instrument. lacunae in research is there is no study from India which has specifically looked into recovery in patients with first episode psychosis in clinical remission, and no study have looked specifically into variables of stigma that affect recovery process in patients of first episode psychosis. The aim of my study was to evaluate psychological recovery and stigma in patients with first episode psychosis and to see if there exists any relationship between the recovery and stigma. The methodology involved 103 patients of first episode psychosis in clinical remission who were assessed on recovery assessment scale, internalized stigma on mental illness scale, everyday discrimination scale. Institute Ethics Committee approval was sought and written consent was obtained from the patient. The inclusion criteria includes diagnosis of psychotic disorder as per many international neuropsychiatric interview 7.0 version, and it was confirmed with DSM-5 criteria for each psychotic disorder. Patients who were in clinical remission as defined by Andreasen et al. 2005. Age group was 18 to 50 years of either gender, with duration of illness of less than equal 5 years, able to read Hindi and or English, providing written informed consent or tele-recorded consent, as the study was conducted during the COVID time. Exclusion criteria, patients not in clinical remission and presence of organic brain syndrome or intellectual disability. Methodology involved the instruments used by recovery assessments. It was developed by Gifford
I request one of the online participants to switch off the mic.
In US in 1995. It is a 41-item self-report questionnaire rated on 5-point Likert scale with adequate test reliability and internal consistency, and covers 5 domains of personal confidence and hope, willingness to ask for help, goal and success orientation, reliance on others, and no domination by symptoms. Hindi translation has been done and scale has been validated. Stigma was assessed by internalized stigma of mental illness scale and everyday discrimination scale. Results of my study is the socio-demographic profile shows that the mean age of the study participants was 26.87 with a standard deviation of 6.9. Majority of the study population were male, 65, and thus with standard deviation of 63.1. Mostly the currently single, unemployed, and education more than +2, belonging to nuclear family, urban locality, and lower socioeconomic status with Hindu religion. The socio-demographic profile of the current study sample is similar to the socio-demographic profile of patients in previous study from this center, except for the mean age. Age of onset of first episode psychosis was 24.29 with standard deviation of 7.47, and the mean duration of illness was 3.05 with standard deviation of 1.41. When this psychological recovery was assessed, it was seen that that hierarchy as evaluated as per the mean weighted score was highest for the domain on goal and success orientation, followed by seeking and relying on and hope, defeated the illness, and least for awareness and control over the illness. First episode psychosis patients had slightly different perspective of personal recovery with more emphasis on goal and success orientation than patients with chronic schizophrenia as reported in the previous study from our center. When stigma was assessed using internalized stigma scale and everyday discrimination scale, the mean score was highest for the domain of stereotype endorsement, which was 17, the mean was 17.93 with standard deviation of 1.94. And the mean weighted score was 2.56. When the variables were, when the stereotype endorsement subscale, it was seen that a stereotype was present in approximately 62, the mean was 62 and with standard deviation of 60.2%. In the everyday discrimination scale, the total score of more than 12 was present in approximately 70 with standard deviation of 68, frequency of 68%. When association of stigma with psychological recovery was assessed, it was seen that the higher level of discrimination was associated with lower level of personal recovery in all the domains. Seeking and relying on social support positively correlated with domain of stereotype endorsement and the total composite score of internalized stigma of mental illness scale and negatively with alienation subscale. There also existed negative correlation of discrimination experience with all the factors of personal recovery except seeking and relying on social support. Further, there existed significant positive correlation of goal and success orientation with alienation. Coming on to the summary, stigma and discrimination is highly prevalent in patients with first episode psychosis currently in clinical remission. Higher level of discrimination and stigma was associated with lower level of personal recovery in all the domains. Neutralization of feelings of being discriminated or stigmatizing feelings of discrimination influence personal recovery in first episode psychosis. Psychoeducation programs and community awareness programs should make stigma reduction as one of the main goals to improve personal recovery in patients with first episode psychosis. Thank you.
Thank you, Dr. Rajlakshmi. There's one question. How do you compare with chronic schizophrenia? Because your patients are already more than 3 years of illness, duration illness.
Sir, we didn't compare the patients with schizophrenia, but the previous studies from our center shows we corroborated the studies, and we through the literature search we found that the stigma was proportionately high in patients with chronic schizophrenia, but there were no studies regarding.
Will you repeat the answer? There was interruption in the internet connection. Will you repeat the answer?
Sir, we didn't compare our data of regarding stigma in patients with chronic schizophrenia, but studies from previous studies from our center and elsewhere in India have shown that stigma is proportionately high in chronic schizophrenia patients also.
Okay, thank you. Okay. Dr. Sandeep, Dr. Manish, any comments?
No, sir.
It was a good presentation. Any more questions from the audience?
We can move to the next presentation then.
Only 3 presentations. So
Okay.
Best of luck to all the presenters.
Dr. Mita can conclude the session, or offline chairpersons.
Fine. We're just preparing the results. We let them know. I think can be done later. Then we can conclude. It was an informative session.
Okay, thank you, Dr. Sandeep and Dr. Manish for joining. And I will conclude the session. Thank you, all the participants. Good wishes to all of you.
Yeah, I'll request Dr. Gulbar Sidhu to felicitate Dr. Purab Midha. And also Dr. Gulbar to felicitate Dr. Himanshu. So we are taking a break for about 15 minutes and we'll be starting the scientific session now at 9 o'clock. the moderator for the session, and he will start the proceedings. So I invite Dr. Nanda to invite the chairpersons and the speakers for the session.
Thank you, Dr. Grover. Good morning, everybody. And the topic is very interesting. Whatever we do, by the end, we have to manage the finances. So I invite the chairpersons on the dais, Dr. O.P. Singh, who is the editor of, is online. Okay. Welcome, Dr. O.P. Singh. Dr. Alim Siddiqui. Dr. Nitin Gupta. He is the president IPS North Zone. Welcome, Dr. Gupta. And Dr. Sandeep Pola, who is the president of the Jalandhar Psychiatric Association and a good friend of everybody. So I hand over the mic to the speaker. Sorry, chairpersons.
Thank you very much, sir. It's a pleasure to be here, and on behalf of my colleague Dr. Bhola and Dr. O.P. Singh, sir, would you like to say a few words?
Just a few words, of course. First of all, thank you and happy Ram Navami to everyone. And thank you for inviting me. It's such a pleasure to be here. And I thank, of course, the President, Dr. Sarma, Vice President Dr. Gul, and Secretary, our dear Sandeep, and all of you for Dr. Gulbahar Sindhu for inviting me. I'm sorry that I could not make it physically due to puja at my home. So my best greetings. And regarding the topic, I must say this is something which is very apt, and Dr. Pramod Kumar is really the likely person to speak on it, because we doctors are known for poor financial planning. We go on working, but we do not invest and we do not plan for the future financial things. Like an engineer from the first year, he invests, and at the end of the day, he has a sizable money, but we earn day to day. And when our earning stops, we find it difficult. Like one of my income tax friends says that why they rate doctors. Doctors are not so rich. But they say that doctors do not have any kind of planning. They do not have any document. So when we rate them, we get easy money. So that's the status. So over to you, Dr. Nitin and Dr. Bhola, for taking it forward because we are offline. Thank you so much, and my greetings to all of you.
Thank you, sir. Before we start off, I'll just say a few words about the speaker. Dr. Pramod, he's a full-time private psychiatrist, a very senior psychiatrist for over 20 years in private practice in Chandigarh. A very dear friend of mine. We did our post-graduation together in PGI. I think, as Dr. O.P. has already mentioned, he's a very apt person to speak on this topic. And I think in this region especially, I think he has been talking about this topic and related issues for quite some time. He's got a lot of experience, and it's not only about financial management, but it's also about sound financial management. So sometimes it comes down to reinventing the wheel. And I am sure that he will be doing justice to the topic and the presentation. So, Dr. Bhola, would you like to? So let's start the topic and invite Dr. Pramod, please.
Thank you, Dr. Nitin, Dr. Bhola, Dr. O.P. Singh, and the organizers, and who have considered me worthy enough to speak on this particular topic. I still remember Dr. Gulbahar called me one day and he says, we have chosen a topic and we have chosen a speaker, and the topic is of your interest. And so he wanted my consent on this particular topic. Thank you. So this is a topic of a great interest. Like Dr. O.P. Singh is saying, that doctors are good clinicians and overall, but as far as financial management is considered, they are considered on the lowest of the professional group. And this particular presentation, I definitely like to dedicate to my dearest friend Rajiv Gupta, who is ailing with an illness, and I talk to him. I keep talking to him about this, and we also share a lot of informations on this topic. And I pray for his best of whatever time he has. So this question always strike me. So whenever I make any presentation, so why this topic? Why especially, and especially in a psychiatry conference? I've never seen or attended a program where the financial management was discussed by a doctor. So there was one program where CA was invited to speak on this topic, and he discussed few things after the end. Because I was one of the organizers, the people were perplexed because there was so much of material they couldn't digest. So this particular topic is applicable to all the doctors, and but however, if we look at the medical practitioners or the physicians, psychiatrist definitely has a different role to play in community. Let us say anything which is happening in the society, you see the press conference, the people, they keep asking you. And in terms of finances, from cash to crypto, we are supposed to know the social trends, economic trends of the society. This is what the society expects from us. But question comes, do we really understand this? I think we do not really understand this. Education on financial planning. So whatever we learn, how do we learn? So this presentation when I made, I discussed with my wealth manager. I read from Motilal Oswal, a lot of literature is over there. I've gone through the book, and I have got a personal experience on this subject, because this is an area in which I am passionate to learn. And that is how I have been investing from the very first day of my private practice. In US, if you look at it, there is only one medical school which has a formal education on financial planning as a part of their curriculum. But at the rest of the places, there is none. And this is a topic, and in India, this is Amar Pandit book. This is Financial Planning for Doctors. It's also a very good book, which is a good book for reference. Normally, also, whenever we discuss informally, also, we do not discuss much on this particular topic. This is something which is, that's why we do not gain much of the knowledge on this. Look at the irony of a doctor's life. The irony is that doctors do not follow the rule that they establish. Like, we first understand problems, people coming to us, we first understand, we diagnose, and then we take appropriate actions for the management. But when it comes to finances, they prefer over-the-counter products. And many of them buy financial products without really understanding them. Due to lack of time and knowledge, doctors rely heavily on the insurance agent who are just looking to increase their sales. And this is exactly what happens. People come to you, many of the time you have seen the acquaintances or the family friends, their children, they come and they sell a product to you, and you do not know what the product is. And out of emotions bonding, you start investing in that product. A lot of people, when they invested in their children plan, they invested in their mutual funds. After 3 or 4 years, they came negative on that. And that not only bring a loss to the economy, it bring a great loss to the relationship as well. So I think we should be very knowledgeable enough, and we should be blunt enough to accept or not to accept a particular proposal. These are a few facts about the doctors and finances. We invest a lot of time in getting qualified. Almost half of our life goes in getting qualified. Late marriage, family, children, and this is spelling mistake. Late earning, delay financial planning. Most doctors earn in 40 to 50 years of age, and it is considered one of the longest profession. And you can work till the time you wish to work. But it is better to plan a retirement life for yourself, especially in a private practice, because in a government sector, you are retired, not by your choice, by the government, and there are few extensions. But as far as you are concerned, if your financial planning is good, I think you can plan your own retiring life. And I have also planned my retiring life, even now at the age of 52. So this is the age for which I will work, and this is how my future would be as far as the economy is concerned. Financial planning also depend on many factors like nature of job. So whether you're in a government sector or you're in a private sector. In a government sector, when you're working, you get a lot of money at the end of your job. So somewhere, and if you have a decent enough kind of a GPF and your earned leave, then gratuity and other things coming all together, it definitely, as of now, I think every doctor would get more than one CR to begin with, and it can go up to 2 CR as well. So from the young people, I always tell, like Dr. Pising was saying, that if you want to have a good financial planning, begin from the very first day you start earning, from the very first day of your earning. It also depends on a solo or a group couple working. Most of the doctors are couples, and so it also depends, that gives them better money as compared to the rest of the professionals. So if you have more, so your planning should also be on the higher side, rather it happen the other way. Then individual versus group practice, the nature of establishment. The financial planning also depends on where you are working. You are working in an individual clinic, you are working in a corporate hospital, you have a nursing home, what kind of an establishment, because many of the things I'm going to talk about, they also depend on the nature of establishment. You should have a set desires for yourself. It should be desire, not a craving or an addiction to achieve something. It should be desire like home, nursing home, hospital, what kind of cars you wish, what kind of holidays, schooling, education is a very, very important part of your planning. So these are normal desires for any doctors to have. What is financial planning? So first question which comes is, what is a financial planning? So it is the process of meeting one's goal or dream through proper management of finances. It has to answer 3 important questions. What are your financial goals? So you have to decide your goals. You can start thinking, it's not a day one, okay, this is a goal I have decided on this particular day. No, it is a process. So you keep on defining your goals. So whatever goal you have decided, see for yourself, where do you stand as of now? How far is it from here? And third is, how will you get from there? If suppose I know the destination, I have to go to Chandigarh, I should know that what distance it takes, how much time it's going to take, which kind of a vehicle I'm going to use. So this is exactly what happens in a financial planning. These are some of the important components of a financial planning. Child future planning, budget and cash flow planning, major purchase planning, financial health checkup, loan restructuring advisory. Your friends or my 8.5%. They were not even aware in a social, when we discussed in a social function, they were not even aware what kind of a rate interest they are paying, what is the left out duration they have to pay, and whether and what is the current rate which is prevailing in the society. I immediately called my wealth manager and I could restructure their loan to 6.8%. Doctors get a better loan because doctors are considered the best people for the banking and the economic sectors, because we pay, we are not dishonest in paying. So that is the reason we have to discuss. If they look at the loan of a 1.5 CR, they must have saved on that particular day at least 40 to 50 lakhs, I can tell you, just by one planning. But please remember one thing, that is not the only objective. That financial planning has to go along with your happiness planning. It is not a question you just keep on saving money and you don't get happiness as of now. And this investment must begin simultaneously. There was one joke somebody sent just a few days back कि कंजूस आदमी कौन है? कहते कंजूस आदमी वो है जो आज खर्च नहीं करता क्योंकि उसको बचाना है, जब वो जिंदा रहता है तो बचाता है कि बाद में काम आएगा, और जब मर जाता है तो दूसरों के लिए छोड़ जाता है. So that is the definition of a conjuice person. So you have to see how much you definitely need to save and what kind of happiness you're gaining out of that. This is called smart financial goals. So an investor without a goal is like a traveler without a destination. Like I was just telling, going to Chandigarh, I don't know where I have to go. I'm sitting on a vehicle, but I don't know. So smart financial planning has to be very, very specific. You have to be specific what kind of a goals are there with you. It has to be measurable. Specific means something like you say, okay, what do you want? What is your goal, financial goal? He says, I want to become rich. That is my goal. But that is not a smart financial goal. It's not a goal. Goal has to be defined. This is what I want specifically at this age. This is my target. This is my target. This is my target. I don't know how many of you follow the wealth management sites. There are every bank, whether you go to Motilal, you go to Aditya Birla, they give you a smart financial planning, and you set in your targets over there, and they will tell you how you are going to gain on that. It has to be measurable, means you should know at what step how much you have achieved. It should be achievable and attainable. And this achievable and attainable, when I started my practice started my residency, I wasn't even sure that I will ever be able to buy a home in Chandigarh. I would be able to afford this kind of a lifestyle. So, but I started my financial planning very early. And this is how the target need to be achievable and attainable. You must know at what age you are going to achieve what, and it has to be realistic and relevant. Tomorrow I cannot say, okay, I'm going to buy Jalandhar, I'm going to buy PIMS, I'm going to that. So it has to be realistic. We should fall within the means of your income, and it should be something which should always be in the ethical and legal norms. You shouldn't do anything to achieve these goals by illegal or unethical means. And it has to be clearly timely or time bound. So sometimes, let us say you in treatment, for example, when we treat people, we know when to decide treatment resistance. There are clear-cut definitions. Similarly, there is a financial resistance. You have set in a target within the time frame, it is not happening. So there are guidelines. Okay, you go little beyond. But suppose it is not achievable, you should leave that. You shouldn't continue to strive on that. This is called FQ, financial patient. It's a balance between income, insurance, and investment. It's a balance of these three. As far as doctors are concerned, our main source of income is either salary or a clinic income. Very rarely we invest in such a way that we get some rental income, because that is never the belief to how we begin our journey into private practice. But this is something few people do get some rental income. Very rare people get into other businesses. Very rare. If you look at the most richest people, like sports person, there was a time Bollywood stars, old stars, they're struggling with money. They are not able to afford their life. Why? Because they never diversified their business. Today, look at Shah Rukh Khan net worth. His net worth is 8% only from the industry of Bollywood. 92% is diversified income which he is getting. So similarly, we have to diversify our businesses. And I have a friend in UK. He's a psychiatrist in US. And he's into almost 40 years into the private practice. He runs 18 clinics, private clinics. And he is a huge businessman. He has a Beverly Hills home over there in the top end. And when I was talking to him, he says his income is only 7-8% coming from the psychiatry practice. The rest of his whole income is from the seafood business. So he runs 5,000 trucks of seafood all over US, Canada. So that is how he diversified almost 40 years back, gradually into this kind of a business. So nobody teaches us, so we don't know that. Sale of assets. Many people start earning. Okay, now we are not working, retiring. Now what do? We have a plot. Let's sell that plot. Let us sell that asset, and they start earning this regular income from there. So that is these are the sources of income for doctors. Now this is a part of the planning. What I'm going to talk about Investopedia. Every one of us must have at least these 6 insurances: indemnity, health insurance, vehicle insurance, life insurance, disability, home or property insurance. And there is a dynamics over there also. So whether you want to have a product insurance or you have a value kind of a insurances. For example, home, whenever anybody buy a home loan, so the company who's giving you loan, they make sure you take a home protect policy. So you have a loan of 1 crore, they will give you a policy and they will start charging. Says they will not charge anything, sir, it will be adjusted. So when they say it will be adjusted, it is adjusted from your income only, from your money only. So there is nothing they are going to put in. So that is, I'm giving you just for example. So you pay something over there for a 1 CR home loan protect, and the company has given you because they want to make sure in case of a disability or death, their money is secure. If I have to plan, I started my journey like that. For the first home loan, I took that. Then I read about it. I says I'm paying close to 10% of the amount in interest rate on that particular amount, and I have to pay back my 1 CR. So why not to take a different term policy, which covers everything at almost half the price. So at the end of my disability or death, this money has to go back to the bank now. So ultimately, if I take a term policy which is half the price, and that will take care of the finances. So this is called a kind of a planning. So you should know that. Indemnity insurance is must for every doctor, whether it is in a private practice or in a government institute only. I'm not sure about how the Consumer Protection Act work in institute. Somebody was telling me that half of the money goes from the doctor's own finances or rest is coming from the institute. I'm not sure on that. How does it work? But the way the financial system, the medical systems is going on, cases are increasing day by day, and with digitalization it will go further. So one must have an indemnity insurance, and the indemnity insurance cover your misjudgment, malpractice, negligence, or any error of commission or omission. You should have an adequate insurance to cover the expected compensation. It is to reduce financial stress and to provide peace of mind. Ultimately, in case of some legal trouble, financially, you have a trouble at this level, but at least financial trouble is taken care of. I believe all of you have indemnity insurance. Okay, if you do not have, please take indemnity insurance. It is must, because one indemnity, you see how the Consumer Protection Act work, how the consumer courts are. So even a district court has been given the power up to the compensation of 1 crore. Even the district courts, which was not there earlier, which was only 10 lakhs earlier. So, and this value keep on increasing because the advocate business, and this is how they calculate. So indemnity insurance, I strongly recommend you must have. I was talking about the term insurance. Single policy with adequate coverage is good. It is generally 15 to 20 times of annual salary or income, minimum around 50 lakhs for a doctor. So whatever is your income, whatever is your salary, 15 to 20 times of that. This is how the economists have defined 15 to 20 times of your annual salary, minimum 50 lakh. Term insurance is something which is not payback. Many people do not understand term policy. They believe it is a, sir, hum to kar rahe hain, kuch mila to hai nahi. Life insurance, it's not like a life insurance money back policy. You do not know. In money back, in ULIP plans, whatever plan you are having, you are actually paying your mortality charges. They're already taking from you. So if they're taking the money from you, which is much higher, so why not take a policy at a much lesser cost, but it won't come back to you. It will only give you peace of mind for your left of people. Health insurance is enough to take care of major illnesses, cardiac bypass, or at least 50% of annual income. Many of the doctors believe they do not need a health insurance policies. As far as health insurance policies concerned, doctors are blacklisted. There are many companies who do not provide health insurance to doctors, including ICICI Lombard till 5 years back. Why? Because they say they can make up bills and they can claim those kind of things. So that is why they were blacklisted. But health insurance today, you see how many of us would go and avail services only in a government setup. You need a private setup, and the cost of treatment for any kind of an illness, it begins from 5 lakh onward. So you should have a health insurance for yourself, for your spouse, for your children till they are adult. The company will give loan is the doctors, highest rated, and they will. So if a loan is coming at 8%, doctors would be able to, if you're a negotiator, you can easily 1% less you can get it. So that is why you are the highest rated from the banking point of view. But always believe it is a money which you are taking and you are paying on that. So take it only when it is really required. If it is not required, don't take it. One of my friend had mortgaged his property just few years back, and he says he got a offer from one of the wealth manager, and he says कि सर आपकी property का क्या हो रहा है, पड़ी है, कुछ कमा थोड़ा रही है आपके लिए, तो take a loan against property, LAP जिसको बोलते हैं, and he took a loan on an interest of 9% to begin with. He says कि we will invest this money into the market, whether it's equity fund or anywhere. So he mortgaged and he did, and some of what happened, the financial equation came down, and he was paying interest on that. So if you're not a very good planner, don't get into this kind of a tricky business. When you have a multiple loans, so please understand the rate of interest and try to pay off the highest rate of interest as quickly as possible. Which instrument carries the highest rate of interest? Anybody has an idea? Uske bhi upar? Yes. Credit cards. How much does it charge from you? तो टोटल इंटरेस्ट कितना पड़ता है अगर आपने पे नहीं किया? 36 to 48% per annum. Highest rate, because they give you money as much you want, depending on your planning. Interest penalty you do not pay every time you. Once I did not pay 48 paisa. I'm telling you, in American Express card. So they levied penalty on me. Then I discussed with them anyway. So the penalty of 3,000 rupees was waived off only for 48 paisa, because their computer, if it is not matching, they will start charging the penalty on that and the late payment fee. So penalty, late payment, and the interest, it comes to 36 to 48%. So if you are holding a credit card, doctor को बड़ी जल्दी मिलता है credit card. So if you are holding a credit card, always read your card agreement, जो कोई नहीं पढ़ता है. Make payment on time. Make a rule. Make payment on time. Pay more than minimum. Ideally, clear the balance. Stay below your credit limit. Check your monthly statement carefully for accuracy. Report a loss or stolen card. Monitor your credit. It's a big asset if you use responsibly. If you have a credit card, if you use it responsibly, it's a big asset for you. You are absolutely, whenever emergency arises, you are there. But it becomes a biggest liability if you do not know how to use it. So credit card has to be used very judiciously. Never just use it. Otherwise you will become a problem. Let us come to investment. The first part is plan income. Second part was insurances. Now third part is investment. Always be aware of the returns. So आप किसी को पैसा दे रहे हो, what you are going to get at the end ultimately, that is the whole target. Why I'm giving money to somebody, where somebody means some institution. Always be aware of the exemptions in terms of Income Tax Act. You must be aware what kind of exemptions you get, and always be aware of the liabilities. If you do not manage your finances, what are going to be your liabilities? Like I was telling you about the credit card. Let us see how many of you आपको पैसा invest करना है. What do you think is the investment where you can put in? Where you can put in money? Fixed deposits? अपने पास रखो. बिल्कुल, इनका भी ठीक है, अपने पास रखो. ठीक है जी, कहीं पे नहीं देना है, अपने बैंक में रखो अपने पास, या लॉकर में रखो. और कहाँ पे रख सकते हैं? म्यूचुअल फंड्स, प्रॉपर्टी, गोल्ड, वेरी गुड, सबको पता है. क्रिप्टो करेंसी अभी लीगल नहीं है इंडिया में. That's it. Okay, now this is a. Have you ever heard about this AIF? ये इंडिया का सबसे बड़ा इंस्ट्रूमेंट है इन्वेस्टमेंट करने का. इंडिया, यूएस, चाइना में सबसे बड़ा इंस्ट्रूमेंट इन्वेस्टमेंट करने का AIF है. आई एम नॉट सेइंग, since it is a presentation for me, and I have to include, and I'm a follower of this. AIF is Alternative Investment Fund. So this is a fund which gives you the maximum returns, supposed to give you the maximum returns. It works like a trust. So this trust is managed by SEBI. So it is a trust of only maximum 1,000 people. But the thing is, you have to begin your investment with 1 crore. And you can maximum pay in 10 EMIs. 10 EMIs of monthly. So 10 lakh, 10 lakh, 10 lakh or AIF. It is only for high value customers. The customers are included only recently in 2021. Earlier, it was not for institution, HNI customers. It was only for institutions, bigger establishments. Lock-in, हाँ, SIP का बहुत ही बड़ा भाई है ये, बहुत ही बड़ा भाई है. Lock-in period is 3 years. Taxation is as per the law, and it carries a high risk. Anything which carries a high risk, if you have a good risk appetite and you have a timeline of minimum 3 years, it can easily give you a return somewhere about 25 to 30% per annum. I can tell you that. So if you have to have a money, and there is a restructuring of money if you can do that. So today may not be possible for many, but if you know that over a period of time, this is an option. Per annum. Per annum. This is the highest institute. This is how the this Reliance and other companies, they work. They invest into it. So we know how many of you have invested in IPOs. IPO में मिलता है? किसी को मिला IPO? क्यों नहीं मिलता IPO? IPO को इंस्टीट्यूशन बाय करते हैं. जैसे पुरानी मूवी में टिकट मिलती थी ना ब्लैक में, किसी किसी को मिलती थी. This is how the IPO work. They collect money and not even individual, not even 1% of the individual get IPOs allotted to them. The rest of the money is taken. So they allocate pre-IPO when the stock is not yet formed. That is where they invested money into. Have you heard about this PMS? Portfolio management. This is the second in the hierarchy. Portfolio management services, dedicated wealth manager with you. They have the highest stocks in their kitty, which is predefined. You have to have a demat account. To begin with, it was 25 lakh to begin with. Now it is increased to 50 lakh. You can have a PMS account only with 50 lakh to begin with. There is a no lock-in period. However, exit load. You know what is exit load? If you withdraw your money prematurely, let us say in this fund, if you withdraw within 1 year, you pay 3%. If you withdraw in 2 years, 2%. If you withdraw in 3 years, 1%. And beyond 3 years, if you withdraw, there is no exit load on this. The taxation, short-term capital gain, long-term capital gain is applicable depending on the government policies. And I think you are aware of short-term capital gain. So whenever you invest, you must know that आपने आज पैसा डाला 1 साल के बाद निकाल लिया within 1 year. So you are liable to pay taxation on that. So if you are taking beyond 1 year, so there is a relief of 5% on this. So this kind of a things you should be aware that this is called a liability. If I'm investing, what I will get, and if I withdraw early, what I'm going to lose. It is also come under the category of a high risk. Stock market. बहुत लोग invest करते हैं stock market में. How many of you are using stock market? Okay, good, very good. And you must, if you are investing in stock market, you must know what is a large cap stock, which is a mid cap stock, and which is a small cap stock. You must know. This is something which is very important. From doctor's perspective, always go in the safest model, go in the large cap category only. If you do not have much knowledge on this market, it require a thorough knowledge and keep a watch. It require you to keep a watch on the stock. Have long-term goal or profit margin of 10 to 12%. Financial wealth manager bolte never love your stock. You are not married to your stock. So there is no relationship, no marriage. So the moment it gives you 12% of a return, you take it out, you sell it. Even if with exit load of 1%, you sell it. When the sale comes, when the market comes down, you again buy it. So 10 रुपया का आपने stock लिया, it become 12, you sell at 12, keep 2 rupees. Again, when it comes to 9, invest 9, This is how this works, and it worked wonderfully. It is highly distracting. I've seen people in clinic, I have seen people glued onto the screen like this. Patient नीचे बात कर रहा है, उनका ध्यान उधर जा रहा है कि सेंसेक्स किधर जा रहा है, निफ्टी किधर जा रहा है, where is my stock? People are using on money control app. So it is distracting because then, but we are not into that category where we have to do BTST, buy today, sell today. Category of long term. Mutual fund most popular, especially with the limited knowledge and low investment and the advertisement which comes with. People are knowing it because on every fifth new advertisement on television is a mutual fund. So everywhere it is there. So that is the reason people invest into mutual fund. The best part is that the very minimum 1,000 rupees you can start investing into the mutual fund. So depending on whatever money you have, you can invest. And power of compounding, you must know. Power of compounding is something, whatever money you invest, it reinvest, it becomes very high. If suppose you invest 30 lakhs into something, 30,000 for a period of 15 years, okay, it goes to somewhere between 1.04 to 1.5, 1.2 CR. It grows like that, compounding, because every time reinvestment comes into, and it charges a fee of about 2%, can be done online or through agents. You can do of your own. Returns are variable, generally 10 to 12% per annum. Capital gain is applicable. You must know there are thousands of mutual funds, So you must know in which kind of a mutual fund you are investing. And there are the classification as per the asset like equity, debt, balanced and hybrid. Equity is pure into stock. So it fluctuates like this. India में अभी कोरोना वायरस का पहला केस आया, स्टॉक मार्केट अगले दिन डूब जाएगी. आज वैक्सीन कितनी लगी है? This is how suddenly the returns will go up. Everything happening in this world, Ukraine war, stock market crashing, because there is a chain reaction which is happening. So you should know in equity, then debt is something like a government instrument, bonds and others. They give you about 4 to 6% only. There is a balance, there is hybrid. Then you should know which is growth factor, growth, investment, liquid investment, tax saving and income. Liquid investment मालूम है? Liquid mutual fund किसी को? Liquid mutual fund होता है कि in which you put park in money over there and you can return any time without taxation, no exit load. आपने FD में पैसा डाला, you can't withdraw prematurely. There is a penalty. You don't get any return, you get a loss. But if you put in a liquid fund, you can withdraw within a month. No penalty, no exit load, and whatever it will give you same return like 4 to 6%, and within a month you will get 6%. So many people as an investor, I say you put your money into liquid fund. It's like a mutual fund. Park in there, and whenever you require, you take it out from there without any loss at all. So this is called a liquid fund. Open-ended, closed-ended, interval funds, then active or passive. Active है जिसमें आपको बहुत सारी चीजें जो फंड मैनेजर होता है, they keep on churning the fund. पैसिव में आज लगा के 3 साल छोड़ दो, बस कुछ नहीं करना है. फंड मैनेजर भी बैठा है अपना, कुछ नहीं करेगा, 3 साल के बाद देखेंगे कि क्या होगा. Then lump sum, SIP or STP. STP, you know that? STP, what is STP? Systematic transfer plan. आपने लिक्विड फंड में पैसा डाल दिया, रखा है, कमा रहा है अपनी जगह पे कुछ कुछ, और आप वहां से एक प्लान डाल दो, SIP, नोट है SIP, वहां से पैसा आपका इन्वेस्ट होता जाएगा ऑटोमेटिकली टू फिक्स अप इट. SIP is something which you manage, you have pre-fixed on that. ULIP के बारे में काफी लोगों को पता होगा. ULIP is investment plus insurance. Lock-in is 5 year. Initially it was 3 year. Partial withdrawal is possible. Switch of option there. Tax-free up to 2.5 lakh annual. Fee include premium, policy administrative, mortality charge, which can goes up to 8%. Many people in ULIP says कि सर उसमें तो कुछ पैसा लगता ही नहीं है. Nothing is to be paid in advance. It is deducted from units only. So you are paying somewhere. At one time when ULIP came into India, the charges were up to 60%. It came to 48%. Now it is almost less than 10%. But still you are paying less than 10% on this. Returns are generally around 12%. The government of India only recently 2020 started using capital gain on this, because earlier 250 countries they had the kitty that on ULIP money returns will be tax free after the lock-in period, but today you have to pay the money on this. स्टेबल रिटर्न ऑन इन्वेस्टमेंट, स्टेबल रिटर्न्स, कुछ नहीं, कोई नॉलेज की जरूरत नहीं है, आराम से बैठो, थोड़ा सा पैसा इस पोस्ट ऑफिस, एनपीएस, ईएलएसएस, सीनियर सिटीजन स्कीम्स, इनमें डालो 6%, आपका पैसा गवर्नमेंट विल रिटर्न यू 6%, नियरली 6%. With compounding, it goes up to 10%. This is the group of people which is the best for the government. LIC is such a big organization. Today, when they will consolidate, it will become much more than Mukesh Ambani's assets. Where is the money? If you read where the LIC is investing, they gave you 6%. They're earning 20% on your money. So they give you 6, 14 they keep for themselves. This is the government of India. They invest money into all these funds. NPS, National Pension Scheme, you get 7.1%, 8% only on GPF. Where this money goes, the government invest into different funds and they earn NPS. If you look at how many of you have done NPS, my NPS is grown up to 35% in 2.5 years. So return on NPS is 12 to 13%. The government of Rajasthan have restarted their pension because the NPS is becoming expensive for them. So return, if you have to have a pension, I would say then go for this. Why to go into the government? If you put the minimum into the government pension, GPF, the rest of the money you invest into NPS. This is the same I did for my wife also. And we get, in PJ, we get 8%. In outside, I am getting about 12 to 14%. So good investment. That is what you're saying after 2004 when the government stopped the pension. So I'm talking about the people who are already into the pension. I can make 100 rupees to 120, whereas the government gives me 108 rupees. Why should I take 120 rupees? This is what I'm saying. This is called a planning, how you can plan your money. Real estate, many people, this is the best investment. People believe that, but this can be the worst as well. I have lost money into the real estate. Always consider beneficial, lucrative. Land investment always better than structured investment. If you have to buy something, buy a plain land rather than a flat or an apartment. Apartment carries the least resale values. Best to invest in, from the doctor's perspective, always best to invest into legal or a government land. Never go into these because you do not know what kind of a litigations comes at what stage. It carries a lot of emotional value. Land. Commercial is better than residential, rental, regular source of income. People say, I don't have as much money to invest. I can't buy a plot in Jalandhar. I don't have as much money. So recently they have come a real estate investment trust. So it's like a stock market, it's like a mutual fund. So you give money to that, like an AF, you give limited money, whatever is money, your share may be 1%, 0.1%, 0.001%, but that money will be invested into the real estate by this trust. It's a very, very popular in Bangalore, in Mumbai. And tax benefits as per the government rules. Investment in gold, like you were saying, it is always considered as a good investment. A lot of emotional values it carry. And whenever stock market goes up, the gold comes down. Whenever market crashes, the gold. That's why in 2008, when the market crashed, India got the least effect of the crashing. Why? Because the reserve on gold is very high. So people like to keep a lot of investment into the gold. You know what is the current rate of gold? 50, yes. And it just look at 3 months back, 48. So this is how the gold is part of the, as for the best policy, your 10% of investment should be in the gold. And the gold investment, if you are not able to buy in bulk, huge money, you have 1 tola, 10 tola, you don't want to buy the mutual fund. There are gold mutual funds. There are gold ETF, digital gold. Then you can invest very limited money. It begins from 500 rupees. And you keep on growing. After about some time, you will have a gold. Physically, gold you can claim back. And best to invest up to 10%. Make a will. This is very important. Many of the doctors, especially, they do not make the will, and that is the reason a lot of you are investment, lot of your assets goes waste and it get into litigations. It is very important to safeguard interest of family and assets. Should be known to at least one close friend or a family member, preferably video recorded. These are the guides the people have given, preferably one of the witness as a doctor. So common financial mistakes made by the doctors: poor debt management. Again, credit card paisa le liya, you are not able to, and that is how you keep on accumulating lot of debts. Insufficient saving, inadequate tax planning, expensive investments when you do investment into so many products, lack of financial projections, lack of insurance and will planning. So you should try to manage these as early as possible. And thanks a lot and happy investing. And please have a set target and you can definitely achieve. Definitely you can achieve a lot by investment. Thank you.
Thank you, Dr. Pramod.
I think he has made the topic very interesting and has explained in very simple ways. And now I request the chairpersons to please honor the speaker.
Okay, thank you very much. Our co-chairperson, Dr. Aleem Siddiqui, has also joined online, I think. So I think I'll just request him to start off with the proceedings from here. Dr. Aleem, are you there?
Yes, sir. Thank you so much. Sir, I think it was a brilliant lecture as always, as it is always with sir. So thank you so much for the tips. I think we'll need to watch it 2-3 times more so that everything sinks in. And rest you can proceed, sir, from the floor.
Thank you. Dr. Bhola.
Thank you so much, Dr. Pramod, for enlightening us on this very important topic and making us wiser with that, what you call that goal, that SMART. So hopefully we get smarter enough to do our financial plannings. Ideally, I suppose that it should be made part of our curriculum, the financial management and administration. But till that time, I suppose these are the best platforms to hold such sessions so that we can, the doctors, the physicians can be made wiser on these financial management and administration aspects. So thank you so much. And I think we'll all should learn from these and we'll all should follow these rules, what you have told us. Now the house is open for any questions, please.
एक क्लास पैसा 2 नंबर का पैसा वो does also decide the investment.
Okay. Jinka, see, people who have white income, so these instruments are only for white income people. That's number one. For the people who have a black money, like sir was saying that कुछ भी मत करो, घर में रखे रखो, ठीक है ना, invest करो ही मत. That is never an objective, because you say money grow only if you let it grow. You have to give the kind of an environment to that money to grow. Black money people, if you have a lot of black money, there are ways that how you can invest a part of that, how you can transfer a part of that, but that's very limited and it should go according to your overall income tax profile. Otherwise, people, black money, they give it on kind of interest to the people, okay, and which carries the interest varies between 12% to 48%. But the risk is extremely high, and because the money returns back to you or it doesn't return back to you, we don't know that. Doctors, why we say we are polished people, we are civilized, we don't fight, we don't argue, we don't avoid litigations, and this is not a business for the doctors as such. So that is the reason black money need to be invested there. Which one?
Calculations. When you file return and tax calculation,
yes, sir,
there are 2 types of filing: old system and new system. In new system, there are no rebates,
yes,
less tax. In old system, there are more rebates, but more taxes,
Yes,
which is
sir.
better for doctors.
No, this is, see, it depend on, this is only for 1 year. It was only for 2021 to 22 that the income tax law was that whether you want to take which kind of an scheme, old or a new scheme. And there were people who got benefit with old, and it was an option for you. Your CA can choose for that. Like one of my friend, in the new scheme, he was to pay a tax of 1,14,000. In old scheme, he was to pay a tax of 65,000 only. There are some rebates of a different kind, so he opted that. But the people who got almost equal, and there are some people who have not invested any money anywhere, so they got benefited with the new scheme. So, but this is not something which is going to carry on. It was tenure was only 1 year. Maybe the government in the next year just abolish that. But that's what I'm saying. ULIP all over the world, 252 countries made a treaty. It will never be. But the government of India in 2021 did not follow that. The government at any point of time can change any scheme, and that is what happens. So if you are having a benefit, avail it today. Don't believe it is going to be next year. It comes, it's a bonus. Otherwise, you stay with that.
Add one thing that what
Next year is not, doesn't the new system doesn't this?
No, what I'm saying, sir, I'll tell you now. What is the, if you follow the income tax side?
Yeah, the new system this time they have been only 1 year. That's all.
No, what I'm saying, the last year when this law came, now you have seen the income tax side recently. The taxation is going to be now smooth. Now, earlier I used to file my returns. I'm saying, let me tell you. Now the government of India, everything now they have come out with a new income tax site. You don't have to put in anything now. This year onwards, all your investments, all your income, whatever is linked to PAN card will be automatically put in there. Earlier, we used to make huge files for long term, short term, where I have invested which money at what time. Today, I don't have to do anything. So this particular change has already happened with the income tax department. What I'm saying, this old and new system, like is saying for 3 years, the government can change at any time. So today, this year, 21 to 22 people have availed. Next year, whether you will not get it, we don't know that. So let's follow the whatever the government will ask us.
I just need to add there, when we were talking about the ULIP and the mutual fund, again, we need to understand that ULIP carries a GST of 18%.
Yes.
Which is not there in the mutual fund. So you actually directly lose 18% when you're investing in ULIPs. That's one thing which all of us need to understand, that if you're spending more money on ULIP and you think that is a safer option, you pay a load of 18% there, which is not, that kind of a load is not there in the mutual fund.
Yes, right. So these are the small things which you must know how much you are paying. ULIP was popular, very popular, till it was not taxable. People used. Then the government of India changed last year that up to 20,000, 2.4 lakh per annum only, means only it will be tax free, rest will be charged. So that is why the government, many people objected, and it increased to 5 lakhs now.
But the entry load is also 18%.
Yes, so that is what I'm saying. This is only beneficial only if you know that you are not going to pay any taxation. The moment the government put taxation, ULIP suddenly came down. It is like a pharma people. Somebody comes one pharma, then the second pharma.
It was a wonderful presentation as always. As Dr. Bola said, we should have some course where we should teach doctors how financial planning. With the permission of both of you and of course Alim Bhai, I want to make just different diverted comment. I think that's very, very necessary. I think as Indian Psychiatric Society should start how to communicate with the patient. It's short course of maybe online, maybe offline, because what nowadays I'm feeling as a psychiatrist, as a private practitioner, हम patient को कुछ समझाते हैं, patient कुछ और समझता है, and that leads to so many this conflicts and this patient आपके against काम करने लग जाते हैं. तो ये जो है ना, मेरे को लगा, though I'm diverting from the topic, but I think it's very necessary. हम जब as a PG में जाते हैं, हम कोर्स पे फोकस करते हैं, हम बीमारी पे फोकस करते हैं, हम कम्युनिकेशन स्किल पे फोकस करते ही नहीं है. I think it should be from this platform I would like to convey. Otherwise, it was wonderful and very learning. Thank you so much.
It's a contract between you and the financial company, and you have agreed to the terms and condition. You are giving them money and they will give you returns. So this is a mutual contract.
Sir, one
Other side,
question.
this is how the marketing happens. I don't know the depth. I do not understand the depth of this. Why it is called only mutual fund, whereas everything is mutual in economy. I don't know, sir. Depend. You tell me how much money you have. I'll tell you. So if you have, let me just give the brief. So from the very beginning, you start. If you have a limited knowledge, start with mutual fund. That's to begin with, and then plan to go up to AIF.
One short question, last. Reliability of your fund manager, AIF, SIP, and STP, whatever these things. What you said is reliable. We rely upon you. Everybody is saying you have explained it very beautifully. And what these representatives, when they come and tell us about these things, how should we rely? Whether the fund manager will invest in those companies which are going up, or this is the main question, and a very short answer.
देखो sir, आपको reliability whenever, this is how I do. So whenever anybody comes to me and discuss their product, I never buy immediately. I tell them to give me the product details, send me an email. I read them thoroughly, and then I can decide. Number one, fund managers are deputed by the companies. The best fund manager in India, there is no fund manager who's above 40 years of age. Their age is between 30 to 40. They're all IIT and IIM and big financial degrees they are holding. You can look at their track record. You can actually see their complete profile. And that is they keep on moving from one. So liability, you have to, because these are the professionals, they manage well, and their whole, you can say life, their incentive, their salaries are based on what they can gain for you, I would say. And part of that comes to them. So ultimately you become the beneficiary. Yes.
Okay. I think questions will keep on coming, or comments will keep on coming, because this is a very interesting topic. And also we've had a very interactive and lively discussion based on a very lucid presentation. Since we are running out of time now, I'd like to thank the co-chairpersons, Dr. Sandeep Bhola, Dr. O.P. Singh, and Dr. Siddiqui. And also thank the organizers for giving us this opportunity. With this, I'll close the session, and thank you once again to Dr. Pramod for his presentation.
I will now request Dr. Nitin and Dr. Sandeep Bhola to felicitate Dr. Pramod Kumar. And I'll request Professor Savita Malhotra to felicitate Dr. Nitin Gupta. Dr. Pramod Kumar to felicitate Dr. Sandeep Bhola. Dr. Pura Midda to felicitate Dr. Nanda. And Now we move to the next session, which will be on physical health of physicians, and this moderator for this session is Dr. Rajinder Mago. So I'll ask him to come here and invite the chairperson and the speakers.
Next topic is physical health of the doctors and insight how we can improve it. As we all know, physical health is as important as mental health. So it is going to be very important topic. I invite chairpersons on the dais, Dr. P.D. Garg, Professor and Head of Department Secretary of this Government Medical College, Amritsar, Dr. Manjeet Singh, Associate Professor, Secretary, Government Medical College, Amritsar, and Dr. B.L. Goyal, sir, is online.
Good morning to all of you. In fact, it's third time we are coming to this auditorium, so very familiar with this. It's the courtesy Dr. Gulbahar and Dr. Dipali Gul and their son, the team of Trio, I should say. They have done a wonderful job, and the topic also they have selected is really very interesting and applies to all of us. We can think in our own self about our own health. Apart from mental health, we can think about the physical health also. So I'm just reminded of the old saying, a sound mind in a sound body. And a sound body has a sound mind, something like that. So without wasting time.
I'll ask him to speak.
Yes. Then he has joined us online. I request Professor Goyal to kindly give your blessings and your comments for this conference on the topic, sir.
Good morning, everybody. Good morning, everybody. First of all, I thank the organizers for having invited this beautiful seminar. Now, I was listening to the excellent talk given by Dr. Pramod on investments. At the same time, a thought regarding a well-known maxim came to my mind. Now, this maxim used to be written on the walls of every classroom of our school. It was like this: if wealth is lost, nothing is lost. If health is lost, something is lost. And if character is lost, everything is lost. Then at the same time, I started analyzing this maxim. Does it stand true in the present circumstances? And I thought of the people who are ruling over us, or who matter, or who are exercising authority over the country. I find that the last thing which we say, character is lost, everything is lost, nobody seems to be bothered about it. In fact, most of the people score very low on this dimension of character. And wealth is lost. They say nothing is lost. This also seems to be untrue to a large extent. But I think it is the health which should be the most important, because if health is lost, then wealth and character becomes meaningless and non-existent. If we die, character disappears, wealth disappears. It becomes meaningless to us. Therefore, I am of the opinion that this topic is very important to us, particularly to doctors. And when we say physicians or doctors, it includes psychiatrists also. Now, as a matter of fact, every doctor believes that this cannot happen to me. When I say this cannot happen to me, means the disease cannot occur to me. Either it is out of
a false sense of grandiosity, or I would say it is out of a defense of avoidance in order to control the fear of having a disease. Therefore, the organizers, in my opinion, have done a good job, an excellent job of having this topic, and have selected a speaker in Dr. Sandeep Puri. I hope this topic will enlighten us and will help us in improving our health. I pass on the proceedings to the chairpersons who are sitting on the dais, and I say good morning. My best wishes to all the chairpersons, the moderators, and the audience who are sitting online, offline. Thank you, Dr. Garg.
Thank you, sir. We are very happy to have your views and comments. So precious for us, because most of us here are only your students only. So, sir, with your permission, I request the speaker of today, Dr. Sandeep Puri, to kindly start his topic so that we can go ahead. Thank you, Dr. Puri.
Thank you, Dr. Garg, and thank you, Dr. Goyal. At the outset, I'd like to thank Dr. Gulbahar for giving me this opportunity. I think this is the first time that I'm speaking in the forum of the psychiatrists. So when about a month ago, he contacted me that we're having this concepts meeting over here, and I'd like you to talk about a topic. I really thought that I've been talking about infectious diseases, I've been talking about rheumatological diseases, we've been talking about antibiotics, so it's an out-of-the-box topic for me. But when I looked at the topic, the physical health of the doctors, and then I started exploring various literature, because we live in an era of evidence-based medicine. I just can't quote my own personal examples as to how the physical health of the doctors can be improved. So once you have to talk to an audience, you have to have evidence in front of you as to what is actually the state of physical health of doctors. And as I explored, I found that there's so much of a trivial data on this. There's so little data which talks about the physical health of doctors. I think it's going to be more of an interaction. I think each one of you sitting over here, their own personal experience is going to be as much of a value as of what I'm going to be talking about here today. As Dr. Goyal just said, we have a common feeling कि मेरे को कुछ हो ही नहीं सकता. We doctors have the feeling of invincibility. We think that we are invincible, and the public, our patients also put it into us. Doctor साहब आपको भी बीमारी होगी. I mean, they feel कि a doctor is immune to any kind of a health issue. So as I explored, I think I was talking to a group of people from the Lions Club yesterday, and my topic was again on a healthy lifestyle. My message to them was कि ये चीजें सारी पता है हमारे को. We've got children at home. We know कि हमने उसको रोज सुबह कहना है कि उठ जा, अब तू अपना जल्दी तैयार हो जा, टाइम से चले जा, अब तू अपना खाना खा ले, अब तू पढ़ ले, अब तू खेलने चले जा. It's a routine. It's something which he knows, which I know, but nobody follows. It is something which we reiterate again and again and again today. So today what I'm going to talk about, what are the issues which affect the physical health of doctors, and are there any ways in which we can improve upon it? So most of you would think that, yes, we are aware about it. So at the end of this talk today, if I'm able to convince one person that, yes, you need to make these changes in your health lifestyle so that you have a better and a productive health, I'll be more than satisfied. And if that person is me myself, I'll be more than happy about it. So WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. We've been talked about this right from our undergrad days, and especially in the SPM, there used to be a question upon what is the definition of health. So we are aware about this, and we don't need to dwell upon it. The current state of health of doctors, most of the analysis has been done on mental health. So we are all focusing on how the mental health has to be good. And as the chairperson rightly said, a sound mind in a healthy body, or vice versa. So a healthy body is always mandatory for us to have a sound mental health also. In the process of focusing on mental health, we actually tend to forget about our physical health. And the brain health, it rests on a heart health. And the biggest determinant of a healthy heart is physical health. So we've turned a blind eye to our physical health. Most of the studies have focused on mental health. We talk about drug dependence, we talk about depression, we talk about suicide. These are the factors we always talk about. The WhatsApp group is full. I mean, the social media has kind of, एक तो good morning messages आते हैं, एक कुछ health के messages आते हैं, और उसके बाद, especially in the doctors group, the messages are mainly concentrated on the violence that has taken place, the suicide that has occurred. Yes, they are issues. They're very, very big issues. But why we get trapped into these issues is because we have lost our focus somewhere. So there's very limited data on physical health of doctors. The mortality data shows that most doctors die from physical rather than mental illnesses. And that's the reason that we need to focus more on our mental health. Now, this is about some studies which have compared the physicians with the general population as to what are the important diseases and what is prevalent more amongst physicians as compared to the general population. So one of them is hypertension. The incidence of hypertension is far more than the general population. Then about lipid disorders, the incidence is far more. Then not been that again appears to be more in the physicians rather than the general population. So in general, the diseases which are related to lifestyle are more prevalent amongst the physicians as compared to the general population. Yeah, that's the highlight over here. So cardiac arrhythmias are more common. Asthma is more common. Thyroid diseases tend to be more common. Peptic ulcers, which clearly have a link with our physical lifestyle, have a more common occurrence amongst physicians. Anemias, they're relatively more common. And as I go on, my slides will depict how ignorant we are about our dietary lifestyles, how it contributes to this. And of course, an element of malignancies tends to be more common amongst physicians. So most studies have said that doctors they take care of patients, but not themselves. And they have a shorter lifespan. There are the mortality data about doctors is less, the mortality rates in doctors are less, but the lifespan also appears to be shorter. Looking at this study, this was a study from the Korean Medical Sciences. As I told you earlier, that there's very limited data available as far as the health of doctors is concerned. So you'd find that the chances of malignancy amongst doctors and nurses are far more than the general population. And so are the diseases pertaining to the circulatory system. This is an all thing about the other things. And in nurses, you find that the external causes of morbidity and mortality due to injury are again more than the general population. Looking at the causes of death in the healthcare workers versus the general population, They've outlined all the common causes of death, and you'll find that the heart disease is more common in doctors as compared to the general population. The intentional self-harm or suicide again tends to be more common than the general population. Chest infections tend to be more common. Then accidents related to transportation have been reported to be more common, and the incidence of falling is again reported to be more common. Now we'll come up to the topic for today as to why do doctors have poor physical health. A gentleman just now commented upon communication. As to communication, so I was just sitting, I thought I'll not take time in the other session. All those sitting over here from PIMS would know, but people who are into general practice and are not conversant with the recent advances as far as medical training is concerned, we do have an ATCOM module, Attitude, Ethics, and Communication. So from day one of the medical studies, on the first prof itself, there are models on attitude, ethics, and communication. Students are given live shows, they're given examples about certain instances, and they're given examples as to how to communicate. That is going to be another game changer as far as training is concerned. Why I talked about this module was because I'll talk about certain other incentives and training schedules which have been incorporated into the medical education system, which are ultimately going to benefit the health of doctors. So what is the reason for poor physical health? Long hours of duty, they contribute to it. One gets lesser time to indulge in physical and leisure activities. The dietary habits, they tend to be poor. There is an element of sleep deprivation, and it starts right from the day you're doing residency. There is a lot of workplace stress and anxiety, and I'm sure all of you psychiatrists are much better placed than me in addressing this issue, and you'll be getting individuals consulting you for the stress and anxiety that they face at their workplace. And the most important, hesitancy in seeking healthcare. And there are various reasons why individuals or doctors in particular do not take proper healthcare. Something which we are all familiar with, we've all gone through. Most of us would be sitting at this stage, but we know that this is the natural life cycle of a doctor, and those who are interested in super specialty courses, they spend an extra 3 to 4 years before they actually start settling down. And we had an investment advisor telling us about how to indulge in investment, but unfortunately, whereas in most other professions, the investments start at 25 to 30 years, you start making your own money by the age of 40, and that's where some people in some professions start off thinking of retiring. Now, why this is important is, again, it's up till the age of 30, maybe 35, max 40, that our body actually grows. It is degenerating after that. No matter how good you look after yourself, how good your physical activity is, how good your diet is, whatever bone mass you've developed up till the age of 35, it's going to decline steadily and slowly. And most of the years that we should be spending looking after our health are spent in doing our education. That's a relative percentage of the number of doctors per lakh population. We've always talked about the lack of doctors availability in this country. There are proposals, there are steps increasing the number of seats, but then the fees also goes up and medical education becomes expensive, and then there are no takers for that. So Punjab relatively is a little well placed that we've got a ratio of around 172 doctors per lakh population compared to a national average of 91. And that's the reason why the shortage of doctors, it implies upon us, it focuses upon us, it increases the burden on the existing doctors, and that's the reason why we have to indulge into long duty hours. Dietary habits. I think how many of you have got a normal dietary. When I talk about a normal dietary habit, I'll be talking about having breakfast between 8 and 9, having a lunch between say 1:30 and 2, having an evening snack, and having your dinner before 9 o'clock. At least I don't. So I don't see any people raising their hands. For me, my breakfast was a cup of milk. Then I used to have my lunch at 4 o'clock and then my dinner at 10:30. That was my lifestyle till about 4 or 5 years ago. And thanks to my colleague, Dr. Sharma, who's the medical superintendent. So ever since he became, so he made sure that I have my breakfast full at 9 o'clock before I come, and दोपहर को 2 बजे उनके phone आने शुरू हो जाते हैं. The lunch is here, jaldi aa, abhi khana hai. So he's made my lifestyle better. So we do have a poor meal planning. I mean, again, these are studies which are there from where I have picked up this data, personal explanations, and looking at my colleagues working in the hospital, outside the hospital, working privately, especially those who are into tertiary care hospitals or even secondary services where they indulge with inpatients, the planning, the schedules, whether it's physical activity, diet, it all goes haywire. We tend to use too many processed foods. We indulge in mindless eating. We tend to eat on the run. I had my breakfast while traveling from Ludhiana to this place, then get up early, couldn't have my breakfast, so I indulged it on the way. Giant portion sizes, too many liquid calories. I met somebody, he says, you doctors drink a lot. I said, well, how do you get that? You go to any social gathering and where there are more doctors, you find them indulging into alcohol. I think that prevalence has gone up. Again, I don't have studies to quote, but if I start doing studies, you'll find that the indulgence in alcohol has gone up. And the reason probably is the stress. It's probably the time that once you're free, you tend to take off your anxiety, and that's why you indulge in too many liquid calories. You tend to skip meals. You got a sick patient. You say, okay, I have to look after it. I mean, that's important, but that's where time management comes in, and that's how you can indulge in it. And then eating from the back, which is the commonest thing, especially in those early 25, 30 years when you're doing the residency and all. You'll find the doctors ordering food and eating from the back. So these dietary habits do contribute a lot to the physical health of doctors. Sleep deprivation. Again, my question to the audience. How many of you sleep more than 7 hours a day? More than 7 hours a day? One, good. So I think I didn't ask any of you who sleep more than 9 hours a day? Anyway, so I'm doing a study along with the presentation that I'm making over here, that how many of my colleagues, so the recommended sleeping hours are 7 to 9 per day. And this study in UK found that 45% of the doctors reported getting less than 7 hours of sleep per night. And an additional, they said that there is less than 5 hours per night. And I'm sure we don't have studies again onto this. The worst thing which I started thinking about when Gulbahar gave me this topic was that I'm going to give the next thesis to my student. I'm going to be studying on the physical health of doctors, because it's an important issue. And the only way I can address it is not by quoting studies from UK and US, but by quoting studies from my own personal experience, which, as I said earlier, I want to create an evidence for that. Workplace anxiety and stress. I mean, it's always common. You sit in a social gathering of doctors. Once you start discussing patients, you always discuss, I mean, two things you discuss. One, about those rare cases where you made an exemplary diagnosis and the outcome of the patient was good. That is what you share. And the second you share, ki ye patient aaya the patient. So this is all workplace anxiety and stress. And this is a survey by IMA, which said that 80% of the doctor in India are stressed out in their profession. 56% of them do not get a comfortable 7 hours sleep most of the days. 13% fair criminal prosecution most days of the week. 46.3 of them fair violence is the main cause of stress in many doctors. Now, these are stray incidents of violence. Ek violent incidents India mein hota hai, it's quoted on the WhatsApp and it circulates all through the country. It's not a rule. It is an exception. But that fear, that has become the rule. 24% fair being sued, 62% they are unable to see their patients without any fear of violence, and 57% have even thought of hiring security in their premises. So the way anxiety and stress is affecting our profession, it does affect our physical health. Both mental and physical health are definitely interlinked, and the workplace anxiety is definitely contributing to it. Now, this is about, these are various studies. There were almost about 26 odd studies where they have seen as to the compliance of doctors in seeking preventive care. So good health, when we're talking about exercise, when we're talking about diet, we're talking about preventive health care. We're talking about issues that can keep us in good health for the rest of our lives. So these studies, they were mainly focusing on 3 or 4 issues as to how many of the doctors were vaccinated, how many of them got their blood pressure checked, how many of them got a lipid tested, how many of the females got a mammogram done, how many of them got a pap smear done. And if you see these figures, and they're quoted from various countries, you've got from UK, you've got from Australia, the Irish Medical Organization, you've got from Canada, you've got from Switzerland. There are variable rates. The rates might be more than the general population, but you should see that we would expect 100% vaccination for hepatitis B. I think all of us are vaccinated for hepatitis B. I shouldn't have a hand raised over here that I am not vaccinated against hepatitis B. Although in your profession, it's more of a discussion that you see. The physical examination may not be a very important parameter as far as the branch of psychiatry is concerned, but getting a hepatitis B vaccination is mandatory for all of us. Look at getting the blood pressure checked in a period of less than in the last 3 years or last 5 years. The figures are good, but again, it's a parameter which everybody can indulge. It's not a very difficult thing. Now, we got accredited by the NABH about 6 years back. And as we move to our next accreditation, it's an important parameter that all the staff has to undergo an annual medical health checkup. We all get a medical checkup done once the doctor joins your facility. Uske baad, every year uska hota hai ki nahi hota, that was not mandatory. Now we have to get it done mandatory. Ab kaise hota hai ki bhai, a consultant in the department would just come in the corridor, Dr. Puri, mera medical checkup siga jara the sign kar do. I mean, that's a corridor consult. It's not even a corridor consult, it's a corridor signature which is there. So if I was conscious about it, I'd rather go to my physician, I'd sit with him, get my blood pressure, my examination done properly, even though I'm feeling that I'm perfectly healthy, but that's screening. And all of us know that 80% of the hypertensives do not have any symptoms. 20% are the only people who have symptoms. So getting a blood pressure checked, which is such an inexpensive, simple, very little time consuming kind of evaluation, even that is not indulged in. And why I gave you this example of most of my colleagues getting their medical checkup done on the run, कि अच्छा ये investigation मैंने blood sugar कराई नहीं, ऐसे लिख दो इसके अंदर. मैं क्या, why? Get it done. Get the figure, the parameter written over here. So we actually, again, the thing which we talked initially, think we are invincible. हमारे को तो बीमारी लग नहीं सकती, तो हमारे को अपना चेकअप क्यों कराने का? One most important parameter, I think this is the most important slide of my presentation. The reason why we are in poor medical, physical health at times is because we have a hesitancy to seek medical care. Now, this hesitancy is based on various categories, and the most important is embarrassment. There is a tendency to self-diagnose. जब भी मेरे को कोई सिम्टम होता है, पहली चीज मैं ये सोचता हूँ कि भी मेरे को ये प्रॉब्लम होगी, एंड आई स्टार्ट द मेडिकेशन माई सेल्फ. Day 5, day 10, day 15, I'm not improving, and then I talk to a colleague about it. I don't improve over the next 4 or 5 days, then I seek a medical consult. So I have a sense of embarrassment कि भी ये कहेगा तू अपना इलाज अपने आप ही करता रहा, तेरे को पता ही नहीं, तेरा ये diagnosis निकला है. So exposing yourself to peers, both personally and emotionally, you don't feel like telling, I mean, unless it's a very usual kind of disease that you might be having, every other symptom you would feel that your colleague might take advantage of you. You're worried that your self-diagnosis or treatment may be wrong. You might have mental health issues because of which you feel embarrassed. A lack of time. आज बीपी चेक कराया था, हाई आया था, चलो दवाई शुरू करता हूँ, कोई नहीं आज कर लेता हूँ, कल कर लेता हूँ. You feel कि आज मेरा काम ये ज्यादा जरूरी है, आज मैंने ये भी करना है. I'll talk to my colleague, I'll get this thing. So there is apparently a lack of time. There is fear of loss of control. You control my own body. The awareness of implications on colleagues, on patients, on getting a future insurance. The knowledge about the subject, that leads you to hesitancy because you easily justify your symptoms as insignificant. I remember a doctor who was 1 year my junior, and she just came with somebody else and made a mention, Sandeep, I've been having this small little lymph node over here for the last 6 months. So मैंने कहा चल आई हूँ तेरे से पूछ ही लेती हूँ. And it turned out to be a lymphoma. And for 6 months, you were just sitting over it. कि भी inguinal lymph node है, ये तो कभी, I mean, it's so common a thing. So the main reason, confidentiality. I think we doctors are to blame for it. We often quote when we are meeting anyone else कि वो आज आया था मेरे को दिखाने, उसको ये बीमारी निकली है. We take pride in naming that person along with his diagnosis, whereas we should not be doing that even for our normal patients. But once we do that for our colleagues, that issue of confidentiality goes, and that doctors might discuss with peers, the staff might find out personal information, the workplace might receive confidential information. So many of my colleagues would not get their tests done in the hospital. कि हॉस्पिटल में मैंने पैथोलॉजी डिपार्टमेंट में सैंपल दिया, इसमें कुछ आ गया, सारे अस्पताल को पता लग जाना है. They would rather go to some associate outside, build up that confidentiality matter, make sure that not even the technician knows कि किसका sample, and then get it tested. The quality of care. There is a failure to treat the doctor-patient like a normal patient. So पहली चीज जो हमारे दिमाग में आती है कि ये VIP patient है. VIP क्यों है? क्योंकि ये डॉक्टर है. And that's the first time when a doctor goes on to a defensive medication, a defensive attitude, the person who is treating it. So the relationship is not like that with a normal patient. Then the culture, both from the doctors and the community. Doctor साहब, आपको भी बीमारी होती है. So the community expects you to be healthy. And that pressure is always on us. We talked about lack of medical training on seeking healthcare. जितने topics हमारे को पढ़ाए गए in all our professionals, in all our MD courses, and even in the discussion prior to this, there is never a topic which is taught to be when we should be indulging into medical care. Like we talked about communication skills, कि communication skills अब हमने पढ़ाने शुरू कर दिए हैं. We should also be creating awareness amongst our groups that these are the issues where you should be indulging. And that's the reason why I'm here talking about this lecture, trying to motivate some of you, including myself, that we should be indulging into activities which can improve our physical health care. So having talked about the issues, so grossly, what are the issues? We are not good on our diet. We're not good on our physical activity. We don't get enough sleep. We are stressed. We have anxiety. And as doctor professionals, we think we are invincible and do not indulge in the proper kind of a medical care that we need to have. So how do we restore our health? So how many of you have a family physician? You are family physicians to so many people, but how many of you have a family physician? Again, so that's how I was thinking about myself, that I have not identified a family physician for myself. I think I'm an internal medicine specialist and I can do whatever I can with my own self. I do have my medical book. Ever since the first day my blood sugar went up and I had high blood pressure, I have a noting in that. If I consult anybody, I do jot it on that. I've told my daughters and my wife that my medical book is in the first drawer of my office. Just in case I fall sick, I fall unconscious, you don't know what has been happening to me, what treatment I'm taking, just open that book. Uske andar, for the last 10 years, every small event, if I had a pain over here, if I had gastritis, what medicine I took, for how long I took, I've jotted it down over there. But again, if I had identified a family physician who was doing the job for me, I'd probably be a little better off. And that's one advice that I would like to give to all my colleagues. Own self, for your regular checkups, who can advise you that these are the parameters. You talked about mammograms, you talked about pap smears, we talked about PSA levels. So if you have a family, we pick up these slides from the Western literature, but they do have implications to our Indian system also. I'm not sure whether it will facilitate the access to the healthcare system, but yes, if there's somebody who's aware about your health issues, if there's somebody who knows, I had a colleague, we were doing a walk and he suddenly collapsed. And we were close to doing a CPR, but he came around, we took him to the hospital. We did all the workup on him. And his brother from US calls up and he tells us that he's got this factor deficiency and he's prone to this kind of a thrombotic event, which so if you have a family physician around and you know that this is your contact number, all our mobiles have got that emergency contact. And if you've saved that number, if that person knows your background, your physical health is going to be better. So that's better documentation and it ensures delivery of evidence-based care. If I have a colleague of mine who comes to my chamber, who narrates his history, gets his physical examination done, gets a slip made out in which I mention all these details and he keeps that record, he's definitely going to fare better in the years to come as compared to an individual who just randomly does a corridor consult. So we always indulge in corridor consults while we are walking up the ramp of the hospital. आपको colleague मिल गया, उसके साथ आपने बातचीत शुरू कर दी कि मेरे को ये problem रहती है, उसने बता दिया अच्छा ये try कर लेना फिर बता देना. So that's the kind of indulgence that we doctors usually have. So incorporate physical health in medical schools. I talked about the ATCOM module. So this is another thing that the National Medical Commission has done. We start off with the foundation course. On day one, when a medical graduate, a medical student joins the medical school, there is a foundation course which goes on for 4 weeks. And in that foundation course, 1 hour every evening is spent on sports activities. And we are having faculty members supervising those sports activities. So जिसने कभी कोई game भी नहीं खेली थी, वो भी आके sports खेल रहा है. Then it has been made mandatory that we have to have 10 yoga sessions for each student, a medical student, in the next 3 months. And on the 21st of June, every medical college all over the country will have a massive yoga session in which all the students and faculty will participate. So this has been incorporated. I'm not sure how many students will follow this regimen, how many of them will continue their lifestyle in which they will indulge in sports, indulge in yoga, but at least there is a beginning, there is a start, there is an effort which is being made to incorporate physical health in medical schools. So this was an interesting article. As to the physical activity habits of doctors and medical students, it influences their counseling practices. So it is not only going to help your own medical health, it is going to help the health of your patients as well. So doctors' health matters, and doctors' personal physical activity practices influence their clinical physical activity attitudes and practices. And this association is strong and independent of many demographic training and clinical practice factors. They found कि जो डॉक्टर खुद एक्सरसाइज करता है वो अपने पेशेंट्स को भी ये सलाह सीरियसली देता है और मेक श्योर करता है कि वो पेशेंट उसको फॉलो करता है. If I have a body mass index of 32 and I'm a dietitian and I'm giving an anti-obesity diet to an individual, I'm very unlikely to kind of motivate that individual into doing that. So all of us should be indulging into this activity. It will make us better doctors, much better framed to treat our patients. So physically active primary care doctors are more likely to offer exercise counseling to patients with cardiovascular disease. This was again in the British medical care. It's an old study, but yes, it still holds relevance today. So how do we restore our health? Again, these are issues which all of you know about. सबको पता है एक्सरसाइज करनी है, खाना ठीक खाना है, नींद प्रॉपर लेनी है, एंजाइटी नहीं करनी है. But we talk about it again and again and again. The reason is, जैसे हम किसी के शमशान पे जब जाते हैं, we see the dead body, we see that being cremated, और उस वक्त सबकी thoughts बिल्कुल प्योर होती हैं कि आज जाके अल्टीमेटली तो यही होना है, तो आज से हमने लाइफस्टाइल ठीक कर देना है. जब हम किसी से लड़ना नहीं है, किसी से ये नहीं करना, बाहर निकलते हैं, वो कार वाला पीछे से 2 बारी हॉर्न मारता है, पहली गाली उसी को निकल जाती है. So similarly, I just hope and pray that after talking about restoring our health, we start having thoughts over here कि हाँ जी डॉक्टर पुरी ये कह रहे थे चल कल से मैंने अपनी physical activity शुरू करनी है. But if one or two of us also start indulging in this activity, I hope all of you are already doing it, and I'm not the factor motivating you, but yes, if any one of us can get better, I think my job would be done. So eat slowly, enjoy your food, chew well. All your gastroenterologists and physicians would tell you that that is how you can kind of enjoy your food as well as digest it better and have more nutritive value. Drink more water, that's the crux. Eat more fruits and vegetables. Work out at least 3 times a week. I think all of us know about that 40-minute schedule 5 times a week. Now there are studies which have said that even if you do a 200-minute schedule once a week, it is almost as good as doing 5 times a week. It may not have too many good long-term benefits as comparable to this, but yes, there are individuals. I'm talking about doctors only. I'm not talking about non-doctors. I'm talking about examples from within the our community in Ludhiana. There's a doctor. He goes to his gym every Sunday from 3 o'clock in the afternoon till 7. He does that phenomenal 4-hour workout, and he thinks that he's done for the entire week. But yes, now there are studies which do help on that. Get a fitness tracker. Fortunately, all these mobile phones and all these watches, now they have got their steps, and it has become almost a fad now to share the amount of steps that you've done at the end of the day, whether it's in a group of family members or it's in a group of your colleagues and friends. But yes, ये ना करो कि भी अपनी घड़ी उतार के अपने नौकर को दो कि 3-4 किलोमीटर दौड़ लगाया. I have to share this tracker with my friends in the evening, so I don't want a step count which is less than what she has done. Sleep for 6 to 8 hours. I have set my routine that I set the alarm at 7 hours from the time I go to sleep. If I sleep at 12, the alarm is at 7 o'clock. If I sleep at 12:30, the alarm is at 7:30. I have to get to the hospital at 8:30, so I'll spend less time getting ready. But this is one habit that I've always followed, that put in a 7-hour sleep, unless of course you have an emergency which disturbs you. Yeah, smile and laugh more. I see very few faces smiling. So all of you can indulge in a good smile and a laugh. I can remember that the first time I किसी ने जोक सुनाया कि भी आपने 100 डॉक्टरों की गैदरिंग की है तो आपने उसमें से एक साइकेट्रिस्ट ढूंढना है, तो वो कैसे ढूंढोगे? जी वेरी सिंपल, आप एक बिकनी वाली लड़की को अंदर भेज देना, 99 उसको देख रहे होंगे और साइकेट्रिस्ट बाकी सबको देख रहा होगा. So I could make somebody laugh. Keep a journal of daily wins, right? I mean, at the end of the day, think about the things that you accomplished during that day. Think about the number of patients you saw, the number of patients who recovered, the number of steps you did, the number of times you ate food, the quality of food that you ate, the sleep that you got. These are all wins that you've scored for the day. If at the end of the day you recapitulate and think about all these things and what you did for your own physical health, I'm sure that your health is definitely going to improve. Many GP ki example di, again I'm quoting personal examples. I can take his name now. Professor Khurana was the principal and he was my mentor, my guru, my guide, my everything. So after his retirement, he went to the US. The day he was to fly back, his son got his health checkup done and they found that he had a tumor in his kidneys. The renal cell carcinoma was there. So he delayed his coming back. He got a surgery done, a partial nephrectomy was done. And then he came back. And once he was back, for the first 6 months, he got his regular checkup done. First of all, there was a debate, why a partial nephrectomy versus a total nephrectomy? Because we in India practice a total nephrectomy much more common. We find our patients are safe. And into the second year, his follow-up with the oncologist became random. I met him after about 4 years of his being diagnosed. I said, "Haan sir, kaise chal raha hai? Theek chal raha hai?" I said, "Did you get your checkup and all done?" "Yeah, theek hi chal raha hai hun. Everything's okay." That meeting, and about 2 months later, he complains of an intense headache. We take him to the CT scan room, and there's an abnormal finding. I take him back to the ICU. मेरे को कहते संदीप, उसमें क्या है CT scan में? मैं कहता sir, the CT is normal. नहीं, go and have a closer look. There has to be bleed in the cerebellum. He was teaching me even when he was so sick. So there was a bleed. We had to evacuate it. Normally, जब bleeds होती हैं, we never do a histopathology for it. Somehow the histopath was sent, and there were mets over there, mets from that renal cell carcinoma. So I'm such an important, such a good physician who taught so many students. Failed on a follow-up. He didn't get his routine parameters done. So just as an example that I'm quoting, that we should have a dedicated doctor to ourselves. You should regularly follow it up. At least do an annual checkup of your parameters. That's the least that you can do to keep your body healthy. So restoration is something that you have to work on every single day, and it's something that doesn't get a day off. Practice it and preach it. And thank you very much for patiently listening to me. Thank you.
Very nice presentation by Dr. Sandeep Puri. Now I would Dr. Goyal to please kindly say a few words.
Thank you, Dr. Puri, for your excellent and illuminating talk. I would like to give an advice to everybody. The steps Dr. Puri has enumerated for good healthy habits, for preventive steps to be taken for early detection of diseases, monitoring, promotion of health, etc. First of all, we should all comply with his advice and instructions thoroughly and religiously, and I would definitely do it. advise your patients, your family members, your relatives, and other people in the community about these steps, which are very simple to take and help us in early detection, treatment and promotion of health otherwise also. I would like to pass on the proceedings to the chairperson sitting on the dais. Thank you, organizers, for having given me the opportunity to be present in this session.
I just forgot to introduce Dr. Sandeep Puri, is principal at DMC Patiala, Ludhiana. Am I right, sir?
Right.
But I think today you are a psychiatrist. Your lecture is that of a psychiatrist, not of a physician. Thank you very much, sir. Now we can have questions from the house. So, as Dr. Sandeep expects that we should all have questions, because all of, yes, come on, Gurinder.
Sir, very nice presentation. My question is that you have given the quote. It happens to everyone, not to the doctor also. You have given the quote to Dr. Khurana also. It happens with every individual. Why doctor special only, sir?
Special is that once we are taking care of the society, why should not we take care of ourselves? It's a personal example which you have to be. I mean, as a doctor, you're not only treating people, you're also a role model for them. And once you're, I mean, it's not that हमने सारी precautions ली, उसके बाद भी we are going to be invincible. We still are at risk. Our genetic predisposition is always there. No matter how good habits we follow, we're still prone to develop ABCD kind of a disease. But whether we indulge in these kind of activities which can make us robust and healthy, or we contribute to our own physical health declining. Yes, society सारों को होती है, but here the group we are addressing is our own community. Why not that we can better ourselves? And as we said कि अगर हम अपना ठीक रखेंगे तो हम community का भी उतना ज़्यादा अच्छा ध्यान रख पाएंगे. अगर हम कुछ चीज खुद प्रैक्टिस कर रहे हैं, it is very easy to advise to the other person over there. अगर हम खुद नहीं करते हो, अगर पेशेंट आपको पूछ ले कि डॉक्टर साहब आप कितनी सैर करते हो दिन में, भाई मैं तो करता नहीं, मेरे पास टाइम नहीं है. अच्छा मैं टाइम निकालूं. So it's an inference, and since we as a community are responsible for the health of the society, we might as well take care of ourselves also if we can take it.
Yes, I think it's only when our life teaches rather than lips that will matter. But the things are known to everybody. The things are known to the profession, but knowledge is of no use. You have to transform yourself. And psychiatry teaches that 95+% part of your body, of your mind is subconscious. And that what matters. And conscious part, the part which knows, is hardly matters. Unless the subconscious mind is totally transformed, it will not matter. And same, it's astonishing to even know this, that with all the knowledge, the physicians are not performing better than general population in health parameters. And somebody, they were selling psychiatry and medicine. There's no difference. Most of our medical disorders, they start in the mind. At least in the mind, if not in the further than mind, the being. And there's a common new science, what is called psychoneuroimmunology. And psychoneuroimmunology, nothing but your all host of parameters from malignancy to infections to everything, starting from the mind. And it's that which matters. And I think this is whole saying, those who can do, they do. Those who can't, they preach. Let's not be just preachers, let's be doers. And the public will automatically follow. Public is like a child. Child will never follow what the parents tell him to do, but child will always ape what the parents are doing. And same has to be the physicians. And the other thing, I think, Doctor, you agree, you have a family physician. I think the physicians is now an extinct species. It's a museum species. Because in era of specialization, we become specialists, become more and more. And the specialist, he who knows more and more, till he knows everything about nothing. And physicians are extremely rare, and they should be encouraged. That's the fundamental thing, I
well,
feel.
fortunately, I mean, as for your last comment, things are turning around. I mean, I go to the counseling in the university. I look at the ranks of the students. So internal medicine again now is a branch which has come up. And if I've got 14 postgraduates, if I ask them, only about 7 of them are opting for super specialization. 6 or 7 of them are opting to stay in internal medicine. So there is a change coming back again. And well, earlier an MBBS used to be a family physician. Now it will be an MD who will be a family, but there is an element of change which is there. And as you rightly said, I started my talk by saying that whatever I'm going to say is known to everybody. Everybody knows about it. There's nothing new that I'm going to talk about. It is only once I'm going to give some evidence with it, maybe it will motivate some of us to improve our physical health if you're not already working on it.
If you go into deeper of it, how the word health came into, health came from the root word whole, W-H-O-L-E, whole. Whole led to H-O-L, whole, and holy, this holy is healthy. This is what the definition of WHO means. In Hindi, Sanskrit, it's purnata, is healthy. And the same in simple word, I, we, illness and wellness. The difference is only I and we. If I works only, it's illness. If we total whole works, it's wellness. And that concept has to be there. And I'm happy to learn that now the trend is coming of having good physicians rather than reductionist medicine approach, partial approach. And this may work in surgery, but in medicine, it works awfully. Thank you.
Thank you, sir, for your very nice comments.
Sir, can I make a comment?
Yes.
Sir, can I make a comment?
Yes.
Thank you, sir. Thank you, sir. I think it was a wonderful and excellent lecture and timely also. Just a few things to add. There was a IMA study in IMA Kerala and IMA Pune, the social security scheme. What they found out that the lifespan of a doctor as compared to the average population was nearly 10 years less. From the social security scheme, they gave this number. Then personal experience, yesterday only we lost a neurosurgeon of our age. He had a discomfort 2 days back and a pulmonary embolism sort of thing 6 months back. So this 2 days back, he ignored it, and yesterday we lost him. Now coming to this, we all have knowledge, we are not acting out. So that grading of insight जो हम बोलते हैं ना कि grade 5 or grade 6, that is intellectual and true emotional insight. We know everything, we are not acting out. So this change of mindset, अब change of mindset is actually very difficult. जैसे हम टोबैको यूजर को बोलते हैं कि छोड़ दो, वैसे हम डॉक्टर को बोलते हैं एक्सरसाइज स्टार्ट कर दो. आई थिंक दे आर नियरली एज इजी एंड एज डिफिकल्ट. सो आई थिंक दिस चेंज ऑफ माइंडसेट, और ये एक्सरसाइज हमेशा करनी है, दैट हैज टू बी केप्ट इन माइंड, and that has to be implied that this 1 or 2 hours or half hour, whatever you are investing, is not loss of time, it is actually gaining of time. Your return on investment is very, very high on this. So I have started exercising. I am into this group now. So and those who are not done yet, best day is to do it today. आज से ही शुरू कर दें, अपने आप चीजें सेट हो जाएंगी. Thank you so much.
Thank you, Dr. So with this, we conclude the session, and we are highly thankful to Dr. Sandeep Puri sir for enlightening us to make us health conscious, not death conscious or disability conscious, as we used to think previously.
Thank you.
So, thank you, sir.
Thank you, sir. Now I request the chairperson to felicitate the speaker. Now I request Dr. Deepali to felicitate Dr. P.D. Garg. Dr. Gurmeet Kaur to felicitate Dr. Manjeet Saini. And Dr. Gurvinder to felicitate Dr. Rajinder Mago, the moderator for the session. Jao, jao. And I thank all the speakers and chairpersons for allowing us to stick to the time of the event. And exactly, it's now 11 o'clock. We break for the tea and we come back by 11:15. डॉक्टर दीपाली ਨੂੰ ਬੁਲਾਓ ਜੀ ਮੈਡਮ ਨੂੰ ਤੇ ਡਾਕਟਰ ਪੀਐਲ ਕਪੂਰ ਨੂੰ ਵੀ ਬੁਲਾ ਲਓ ਹਾਂ ਬੁਲਾਓ ਜਲਦੀ ਬੁਲਾਓ डॉक्टर गुरविंदर अपना सबसे सारा खुला टाइम देता है खुला टाइम देता है 10 मिनट की कॉल 15 मिनट करूँगा कोई मजा नहीं वहाँ जल्दी Okay, welcome back, all of you. And we are now going to start the next session, which is an important session where we are going to discuss about suicide in the medical professionals. And for this session, the speaker is Dr. Gurvinder Pal Singh, and the chairpersons are Dr. Dipali Gul, Dr. Aseem Mehra, and Dr. TL Chopra. I think Dr. Chopra is outside, he's just joining us. So Dr. Dipali and Dr. Aseem can come onto the dais and start the proceedings.
Dr. Gurvinder Pal is currently a professor and HOD in Department of Psychiatry in AIMS, Batenda, and he's a well-known academician, a good clinician too. He has a number of research. He's more interested, area of interest in mindfulness and yoga. So I would like to invite Dr. Gurvinder Pal.
Respected Chairperson, let us see Mera, Dr. Dipali Gul, Dr. Chopra, very senior psychiatrist of Punjab and Chandigarh, Dr. Sandeep Grover, Dr. Gulbahar, Dr. Manjeet, Dr. Gurmeet, Dr. Pralita, and other very senior psychiatrists. I'm grateful to the organizer for giving me this opportunity to have a talk on this very sensitive topic. Dr. Gulbahar called me in the evening. When he gave me this topic, I was very much shocked how I will prepare it. Then I talked to my junior resident, Dr. Sonali. She said, Dr. Society, koi aisi baat nahi hoti, we will prepare the slides. So I give all this credit to my junior resident, Dr. Sonali, for this. As Dr. Sandeep Puri was saying a very important lecture, yesterday also, Dr. Grover lecture on burn. So I have prepared my slide according to that, but due to rescheduling of the this presentation, so what I'm going to talk is just the summary of what we have spoken yesterday and today. So before this, I'm really impressed by the Dr. Gulbahar Sidhu's involvement since yesterday. So I will start with the share. छतों पे रखे चिराग कब के बुझ गए होते, कोई तो है जिसने हवा का रुख बदल दिया. So the topic is suicide in medical students and medical professionals. I will briefly talk about the epidemiology, the risk factor, and intervention. I will talk about background, and this preventive strategy is more important. As Dr. Puri was saying that doctors are they are VIP patients and very difficult. I talked to him that for this condition, it is more tough also. I still remember I was discussing with Dr. Prajita when I joined GMC at Chandigarh first day. Our ward was in the 5th floor. One patient of ours committed suicide, and that was very tough for me. Then I realized we should do something for this problem. So I have written an article on that day. I give it to my HOD for 2.5 years. That article remained on his table. So I repeatedly asked him to clear that article. When we sent this article to Indian Journal, the editor was so impressed. He was also the editor of International Journal. So he published that in International Journal. So my first publication was in the International Journal. So whenever MCA used to come, they used to see that article also. I'm just giving some news clippings and others. Very distressing words are these. According to Indian Journal, 30% Indian doctors and physicians go through depression, while 70% have thought of ending their life. I will go into detail later on. Physician suicide is a public health crisis, and about 4 doctors per 10,000 people commit suicide every year. Out of 30 suicides, majority of suicides were from the medical education institutions. A study on suicide among Indian doctors published in June 2021 pointed out that doctors have higher suicide risk 2.5 times more than the general population. So this is a very big figure. 30% doctors are affected. IMA demands law to protect doctors. So we are in a democratic country. So rules are there, but implementation is the problem. Doctor found dead in the hospital. Doctor couple commits suicide in Pune, published in Times of India. When this news become the burning issues, And so many things are there. So this become a headline also. This is very, very interesting slide. I'm working in Chandigarh. I've seen that sometimes I go to PJ emergency. I just go through that. I just see how the junior residents senior are working there. They are really angels like. Whenever they have some seminars, the emergency duty, very happy to go to emergency. There is a big line of the patient also. So AIMS Faculty Association written, the Faculty Association of AIMS has written to the institute director to take urgent action to prevent the spate of death due to suicide. In the past 2 months, 2 students, one undergraduate and another postgraduate, and a medical scientist of the PEX Medical Institute of the country have killed themselves. It is a matter of great concern. We have written to the director to collectively think and take steps to ensure such incidents are not repeated. So this is very big. So these big institutions, they have a very, this high risk also. So if I write to director over spate of recent deaths. COVID-19 pandemic, a month treating corona patient in ICU, Indian doctor commits suicide. Those who have worked in the ICU corona ward, they must be knowing the reality. Fortunately, COVID ward. And when I started working there for 1 week, the director was so impressed, he increased my duration to 1 month. I talked to that director, I worked for 1 week, and you are posting for 1 month, give me 1 week break. I've written so many letters, but she was not agreed. So I have spent 1 month there. The conditions were really horrible. Sometimes there were neither any attendant, only doctor was available, and the patient's stuff was very tough. I passed through very horrible time during that 1 month also. So this is very tough condition. So question arises, medical student, the medical workforce of tomorrow, they are looked up to save the lives. Some say they are angels, some say they are second to God. So many things are being told. But why this is happening to them? What then drives them to take their own lives? So this is a very mystery question. Since yesterday we are talking about it, and those who have attended yesterday, Dr. Grover lecture, Dr. Anjali, they must have some now conclusion why it occurring to this, because they are also human beings. They also have the same need. So if you see the Maslow's hierarchy, some basic needs are there. So another hierarchy is there. Topmost level, but we are talking that is just a utopia. So this is very important. What then drives them to take their own lives? It is a very complex, multifactorial issue. Increased checking by medical professional student in psychiatry was, as I already told, Indian Medical Association done a very good work. They labeled it a public health crisis to be tackled before it is too late. Suicide rate higher than in other professions. Basically, what is happening is, it is a global phenomenon. Everyone knows about it. Every 40 seconds, a person commits suicide. Very big figure. World Health Statistics 2019 suicide mortality rate global was 10.6 per 1 lakh population. India, it was 16.3 per 1 lakh population. This is very interesting slide. Suicide rate in medical profession is more than suicide rate in general population. Everyone is discussing it. But why it is so? Can it be prevented? So I will just talk about it. It's more, we have to accept it. Unfortunately, we have a denial also. We never accept it. So we have to accept it. This is all the crux of all the finding. Whatever the journal, Indian journal, international journal, suicide rate in medical profession is more than the suicide rate in general population. We have to accept it. Another question, very important. What about the male or female? Male physician, female physician. That is also equal. So there is no any difference between this. So if it is a male or female, sometimes says that female doctors are more stressed, or male, the question is almost equal. So there is no any sex differences between these rates. Another very question is, what about the North India and South India? If you see geographically, South India is giving more reporting, 57%. North India is less. The reason may be more research in South India than in North India. In North India, PGI has done very good work. So if more studies are there, more data is available, then North India could be also there. But it is, as per the information, it is more in the South India. So there are particular spots are there, particular medical colleges are there, particularly that is there. So this is again a very important finding. As I already told, PGIMR has a very good study. 30% of the 445 doctors who participated were depressed. Very, very frightening feature. 17% thought about ending their lives. So this is very, very important. So this is whatever research we do. Unfortunately, what happens is that is not converted into practical aspect. Research is there only in the journals. People do not go through it. Then we have any policy or something like they should have gone through their data also. They should summarize that. And that is very, very important from the Chandigarh also. If we do it in Amritsar, if we do in Jalandhar, if we do in Amritsar like that, so that data will be there. Unfortunately, North Zone research is very, very limited. If you go to the South, so many conferences, so many papers are there. So they are particularities, so data is there. Another very interesting is that in a poll of 45 doctors, 62% of them said it is a long-standing problem. And very interesting. Say that it was happening for the last 10 years, 15 years, now there's something precedent is there. So it is a long-standing problem, not a only being reported better now. Reporting issues are there. So as I've already told, COVID-19 pandemic came, first wave, second wave, everything was in prominent. Journalists were very active. So doctor cases also started coming out. So this reporting issue was due to COVID pandemic. But they said that is a long-standing problem. More of these doctor suicide are getting reported prominently as compared to the past. So this is again very interesting. So COVID pandemic. So there was mental health tsunami. So many things are there. So this has got prominent. And fortunately, doctor are being respected also. I just in GMC, there were helicopter with roses thrown or there. So ceremonies were there. Doctor were respected also. So with these come into the front highlight. Media also become over reporting. So this is very, very important in this poll. It was found that. Another, which I've already told that, yes, data is more about the South India, but it is a countrywide problem. If problem is that research has not been done. PGI has done very good research, but that is only this area. So if done in other also, so it is a countrywide problem, not limited to this situation. Reporting issues are very, very important in this case. Another very, very interesting is which are the department? Anesthesia, general medicine, and psychiatry. Undergraduate medical and dental students are also vulnerable. Suicidal ideation among medical students ranges between 1.8 to 53.6%. So see the range is a very, very huge range. Into 2020, most students' suicide occurred in the month of result declaration. This is again very. I still remember when I was in the +2, my father told me you have to come top in the class. So second बात तो कभी हमें बताया नहीं गया, हमें कहा कि आपने फर्स्ट ही आना है. तो ये चीज जो है रिजल्ट वाले दिन बहुत महंगी पड़ती है. I still remember when my PMT was there, I have gone to Modi College Patiala with my father. Unfortunately, light was not there. So when I was sitting in the hall, I just go seeing my father. Sir, if I do not get selected, what will happen to me? So I could not get selected during my first attempt. So next time I did not carry my father along with me. I went alone there. So this result declaration is very, very important. That is very, very important. Most of the student commit suicide occurred in the month of result declaration. So this is very, very important. But I'm talking about the whatever research tool that can be done in prevention. Whenever the result declaration is there, our Honorable Prime Minister has also given views about it. We have to do something counseling before that. So everyone cannot be a topper. So someone has to come second also, someone has to be fail also. So these most very, very crucial aspect, result declaration is very, very important. Among medical professionals and student is 11.1%, range of 7.4% to 24.2%, more common in female, first year and Middle Eastern students. This is very interesting slide. Risk side is 10 times higher in patients with pre-existing psychiatric conditions. So if a doctor has already psychiatric condition, then risk is more. If we compare between general population and medical student and professionals, spellings are wrong there. So there is a different reason. In general population, depression is 30% cause, substance related 18%, schizophrenia 14%, personality disorder 13%. In medical student, anxiety is very at the top, 66.9%, stressful conditions, stress related disorder 53%, depression 51.3%, and substance abuse is 15%. So there is a difference between those. So anxiety and stress is very at the top in medical student and professionals. So another way is occupational stress and burnout. Yesterday, Dr. Grover has given a very good lecture. Those who attended it, they must go through it. And it was very important. What is burnout? How it is defined. So this is leading cause for psychological distress. Burnout is very important. And it is very common in medical professionals, and particularly COVID-19 pandemic, who were in very frontline workers. They have got this all was there. So prevalence of burnout 50 to 76% in medical student and professional. And this was a very important cause that can lead to various consequences are very harmful. So this occupational stress and burnout is a very important issue. We must go through it. We must read it. And research has already been done. And this is very important parameter. When I will do in prevention, then I will do how we can handle it. So medical professional face different struggles at different stages of their career that affect their mental health. So this is very important. When a person, I still remember when I was in the first year MBBS, ragging was a very of the ragging. Examination, first prof, second prof, final prof, then internship. So struggle is there, then junior residency, senior residency. So this is at each level step. We have to accept it. So just entering into medical college, you are not becoming a doctor. So that euphoria lasts only for 15 days. Then you realize that actually the struggle is so much, you become difficulty, then promotion is there. So struggle is going on like throughout the lifespan. Medical student interns face exam-related stress. Particularly focus is on interns and resident. They are very particularly about this. The most of the their issues are but related to internship and resident. What happens in an internship? They have to get registration also. If they have got any absent, so they have to repeat that also. I am working in GMC. I've seen that interns are very tense. They are posted in emergency. They are in night duty. So they have to get registration if the 1 year is complete. If 10 days or something there, they have to again it. So similar with the resident, because that is a 3-year period. So they have to, so many things, thesis there, they have to submit the protocol, so many last date are there, examination dates are there, then COVID camp there, their results were postponed. So these interns and residents are more prone to this condition because of sleep deprivation, poor living condition, competition from peers. Many students would take place during exam time. I've already explained to you. So if just you summarize the causes: toxic work environment, bad living conditions, academic stress, work harassment in form of discrimination, ragging, nepotism, struggle to provide the best service due to lack of adequate hospital supplies and infrastructure, marital discord or relationship issues, knowledge of potentially lethal drug. This is again very important. I have told you that anesthesia peoples are they know everything about it. Whenever they know about it, the lethality also. Violence against doctors. So many things have been there. So this is again a very important, because doctor has already worked so much hard, night duties there. So they have got 24-hour work. And then there is violence from the public. That's again a very important factor. Witnessing trauma at such close quarter and constantly. Stress of saving lives, taxing medical training, long working hours, less time with family. So so many issues are there. These are very just crux of the causes of this particular problem. These contribute to high prevalence of depression, 35%, anxiety, 40%, stress, 33%, and burnout, 91% among medical student and professional. This contribute to suicidal ideation. This is even higher in students of lower socioeconomic status who had physical symptoms such as non-inflammatory joint pain, headaches, and sleep disorder. So this is again a socio-economic status pattern also. So this is again because they are from the different families, they do not have income sources, so many issues are there, you require so many books there, money problem is there. So these all accentuate, they have to fill the tuition fees also. In private colleges, so many fees is there, so last date is there, so they will fine you if you do not deposit the fees at particular time. So these variations multiply in these students. As I've already told, there was a long-standing problem, but this COVID-19, a new stressor came. COVID-19 and lockdown increased suicidal and self-harm tendency among doctors for 42%. So salaries were also there. There were also some people were on contract, someone outsources. So they were not given salary by the 7th or 10th. They were given salary later on, but they have to pay the rent. They have to give so many resources are there. So delayed salary was there. Hostile work environment, PP availability and quality. So this was again issue. When you go to COVID ward, it was not as freely available as it should be. So that is a very important. Patient is serious, you have to go inside, but the PP availability is there. So they got entrapped into that. Unhygienic quarantine facilities. Those who have worked in the COVID ward, neatness, cleanness, it was very horrible there. So it was very, very tough how to do this. So about extent of support from the institute. As I've already told you, I talked to my director, joint director, I written 15 to 20 letters, but no one listened to us. So this was happened, uncertainty about the extent of support from the institute, frustration of not saving lives, separation from families, violence and discrimination against COVID warriors. So this was also found during this COVID-19, a new stressor. So these all things precipitated during this COVID-19 pandemic. Another was the method used. Socio-cultural differences govern different methods in different countries. In India, hanging is more than the jumping from the building, which is more than the lethal injections. As compared to in other countries like Australia, poisoning is more common cause. In USA, everybody knows firearm is freely available. So their license they have got, so they use this method. But India, hanging is very, very more commonly formed method used by these who commit suicide. Now I'll just start talking about the prevention also. Everyone know prevention is better than cure. So this is very, very important. Particularly suicide is such a condition, it can be prevented because so many clues are there, so many signs are, I will just explain. So prevention can be there if we all work together and do something for this. To be able to prevent, one must identify and distinguish the risk factor and warning sign. What are these risk factors? So this is a holistic list. Risk factor for suicidal tendency among medical student and professional, as I already told, anxiety, depression and reaction to stress, prior history of self-harm, personality traits of aggression and impulsivity, depression in primary relatives, gender differences associated to sex and violence, marital problems, financial difficulties, family disputes, parental death by suicide, housing, insecurity, living alone, and break in a steady relationship, chronic pain, and perceived humiliation. This is also a very, very risk factor. Where my head of department has humiliated me, something has done me in front of the other, during round, something has happened. So these humiliation, they go on hindering for this. So this is also again, because we have a different type of egos. So if you have a narcissistic injury or like that, so that perceived humiliation go on for a long time. So these are various risk factors. So these are the warning signs for suicidal tendency among medical students and professionals: hopelessness, rage, anger, revenge-seeking behavior, reckless and risky behavior, increased alcohol or drug use, social withdrawal, feeling trapped, anxiety and agitation, sleep alteration, dramatic mood changes, no reason for living, or no purpose of life. This line is very, very important. No purpose in life. I still remember when I joined MD Psychiatry, my HOD told me that whosoever patient comes, you have to ask the question of suicide. If you do not ask the question of suicide, you are doing some criminal work. So I just when I asked from any questions regarding society must be asked from everyone. So this is very, very important. No reason for living, no purpose in life. I will just explain later on about this. So what are the preventive strategy or intervention? I will just go briefly because it is very, very different type of topic. I will just briefly about mental screening and checkups. So it is not routinely done, neither any medical, something like this. So this is very, very important. As Dr. Puri was telling about the physical health, everyone go to check his blood pressure, so many things he was telling. But what about this mental screening and checkups? So this is very, very important for prevention. Mental screening of medical students and professionals, prompt referral to mental health professionals for detailed evaluation, provision for tying up with another institute different from the parent one to maintain confidentiality. Again, this is a very administrative reason. So we have already talked about why it should have been done. So what are the maintain the confidentiality? So this is very, very important. If we maintain the confidentiality, because problems are coming, problems are going. So if we maintain the confidentiality, as we do with the other clients, with the doctor also, with the medical student also, this is very, very beneficial. Provision for tying up with another institute. This is very, very important. Again, very interesting, awareness. I am really thankful to Dr. Gulbahar Sidhu that he has conducted this type of lectures. This is the theme of this. So these type of workshop and health camp should be conducted at regular intervals among awareness. So whatever we learned from last 2 days, so many things we have clarified, even like this in the institution, in the public, in the another forum, various Rotary Club and so many things. If we do it regularly like this, governing various medical colleges, it is a very, very important. First of all, you have awareness, then you have knowledge, then you trial, then you have acceptance. So awareness is very, very important. We are not aware about it. So even doctor not aware, how we can be aware the general society also. So we have to aware about the risk factors and warning sign of suicide. Stress management is very, very important. I do not know, as Dr. Puri was saying about the physical exercise. So stress management is also very, very important. Mind exercises, what are those? Dr. Asim Mehra was telling that I am very interested in mindfulness. So mindfulness is I am giving the lecture. I have to be fully focused, but I'm going to talk. You are the listener. You must be very focused, but you are going to listen. So mindfulness is very, very important technique also. I will just I just 1 minute more. Healthy lifestyle. Dr. Puri has told. Abstinence from addictive substances. So if you have seen the risk factor, alcohol abuse, substance abuse, a very, very high risk factor. Whenever I see the research in the suicide, this is a very strong association between the alcohol use, substance use, and suicide is there. So this abstinence is a very, again, a utopia-like, but it is very, very important in the prevention strategies. This is very, very interesting. I do not know whether anyone know the particular day when is this suicide, this day. Suicide September 17 is dedicated as National Physician Suicide Awareness Day. So this is very, very important. If we celebrate 17th September together, so many things are there. So we can prevent suicide if we work together. So like World Suicide Prevention Day that on 10th September. So this is the September 17 dedicated only as National Physician Suicide Awareness Day. So this is very, very important. So now I'm talking about what are the work stress prevention. Good living condition like hostel for student. Recently, I was given order from my institute for physical verification of the hostel. When I went to their common room, it was very horrible conditions. So it was not very clear. I was just thinking how the doctor would be sitting in the common room. The conditions were very, very bad. So if the hostel facilities are fine, good living condition like hostel for student, institute should look into the way examination are being conducted. So there should be some gap like this. I still remember when I finally MBBS, we were having daily examination. So if 1 day, 2 day rest is there, then examination is there up in the theory exam. So that is very, very beneficial. Schedule should be like as this administrator can do it. Teaching stress management skill, focusing on behavioral and cognitive strategies, evaluation of the work-related stress,
burnout and depression among doctors and address the same. From addressal of the complaints or harassment by a neutral authority or designated body. So this is again very, very important. I complained about this and it linger on for 6 months and for 1 year. So that is have no value. So doctor has to do something like that. For example, I go to store, I got something different from that. So I have to report to the medical superintendent that I'm not getting this supply from the store. But the issues are not resolved and it go on going around. So this prompt addressal of complaints of harassment by a neutral authority or designated body, social and recreational activity, good nutrition and exercise, regularize fixed duty shifts and work hours with adequate breaks. So this is very, very important prevention strategy as far as work stress prevention is concerned. Another very COVID-19 pandemic is given teleservices also. So this telepsychiatry, some were doing very, very good work. Like Kiran, a 24/7 national helpline set by the Ministry of Social Justice, dedicated for medical professionals. Suicide Prevention India Foundation having teleconsultation option and suicide gatekeeper training program. This gatekeeper training program are very, very good. So these are well documented also, very simple also, but we have to learn about it. In GMCH, we have ASHA helpline, it is working since 2003. So they can talk to that. Some venues there so that they can discuss their minor issues. Through its doctor to doctor program, Indian Medical Association organized self-help and awareness campaign. Similarly, in 2019, the association released a mental health guideline for medical students and more recently published a book entitled Surviving COVID-19 as a Medical Student. So Indian Medical is doing very good work. I hope that our Indian Psychiatry North Zone, this PUNJAB, these also start doing something for this, and IPS is doing very good work, but we have to sustain it first so that the problem is long standing. So according to that, the solution should also be there. So these interventions are very, very beneficial. We can ventilate their feeling and that can be resolved. Other psychological helpline available for the general public are I call by Tata Institute of Social Sciences, helpline by Mumbai-based organization such as Asra and Smarty in Mumbai, Goa-based organization. This Sneha Foundation is doing very, very good work. Who want to take training, they are doing very good work, and these other centers are doing very good work. So this requires training and research center. So these are very, very important preventive avenues, and these should be available because suicide can be prevented because their issues are very, very small. If they are tackled at a particular time, so this problem can be solved. This is a very, very important slide. If you just, most of our issues can be resolved. So ironically, stigma associated with mental illness is magnified in medical profession. So destigmatizing is foremost. I was discussing with Dr. Sandeep Puri that people are very comfortable in going to the neurologist, physician, but they are not, still stigma is there. Dr. Sandeep Grover has conducted recently a study, still stigma is very, very high. A person with schizophrenia, they have more stigma than person with bipolar disorder, than with person with depressive disorder. And this article was published in very two international journals. So stigma is still prevalent. We are talking so many things. So this destigmatization campaign has to be there. It has to be consistent also, particularly in the medical profession. Just on this Thursday, when I was in the OPD, I seen that medical students, they just don't like to come in the OPD. They want to meet you in the parking. They want to come to your house. They want to telephone you. So stigma is still there. If in our undergraduate psychiatry courses, psychiatry is given some marks, 50, do something, because at the top, we have a very good psychiatrist who was an enhanced director who's posted there, that Gangadhar is there. So if you do something in undergraduate courses, like orthopedics has a separate exam. So if you do this, so this can be helpful in destigmatization. They're told about the mental health issues. They're told about the depression, so like that, but there should be some exam also, even for 50 marks is there, but now till date there is no such exam of 50 marks, so that problem go on. So that could be very, very effective. So this destigmatization is very, very foremost, and particularly in suicide prevention. So documentation of suicide risk is very, very important. Screen and document for suicidality in those reporting suicide ideation. Develop a structured suicide risk assessment tool. Suicide risk assessment, establish the intent, assess the seriousness, and perceive seriousness of their attempt. Assess how they feel about the attempt at the time of assessment. Key questions to ask about the current episode of self-harm. There are 3 conditions: before, during, and after. So we have to question according to that also. Asking patient if their thoughts are killing them is a good start to evaluating suicidal. So this question is very, very important. If you go to the literature, asking this question, patient gets so much relief also. Complete evaluation of the plan, including the chances of rescue, preparation for rehearsal others and must be obtained. So these are risk factor, warning sign, and must be noted. So documentation is very, very important, particularly in the medical student area. So these can have so many issues later on. As I already told you, we have to ask open-ended question. This is very, very important. We should not ask closed-ended questions before, during, and after the act. So just simply ask, tell me what happened. Then you ask what happened next. So before, was there any precipitant? Was planned or impulsive? Did carried out final acts? Written a suicide note? Leaving a will? These are very, very important signs. Terminating contracts. For example, he had disconnected mobile phone. Gas and electricity are there. Were any precautions taken? Closing curtain like, locking doors, waiting until they knew everyone would be out of the house, going somewhere remote place, living at undisclosed places. Was alcohol a substance used? What was the amount and type? Any previous substance use? So during act, we should know what was the method, whether he was alone, where were they? What was going through their mind during that act? How they ended their life? They were planning it. What did they do after it? And after it, did they call anyone? How did they feel? Any regret? What was their mood? Are still feeling suicidal? If they were said to go home, what would they do? If feel like this, again, it is differently prevention, anything to live for, or they will accept it. So many questions they can ask. So this during and after, and this is very, very important. And you should ask open-ended question to students. Another very important is the overdose issues are there. As I told you, they know everything about the drugs, pharmacological actions. They go through the net also. So this is very, very important. Overdose is very, very important. So what medication did they take? Where and from whom, how much, and with what was the amount of the medication, and decision how long they were thinking about taking an overdose, after taking what he did, and how they reached the hospital. So these are very, very important questions, and they give very, very important clues about the particular issue. So we have to ask specific question about the cutting also, and we have to screen for disorder, screen for depression, psychosis, previous episode, past psychiatric history, medical history, drug history, and family history. Living condition is very, very important. Must give some minutes to it, and that should be so. What are their sport network? How many their friends, a circle is there? Activities are daily living, and occupation is very, very important of the family members. Various important scales, I'm not going to detail because these are very, very important scales. Scale used to identify suicidal risk validity in the Indian setting include sad person scale, Beck suicidal intent scale, suicide intent questionnaire, Columbia suicide severity rating scale. These are very, very beneficial as you can pick up. So these are very easy to use. They're not very tough, but I'm not going to detail another lecture. So question is on the prevention. Intervention for suicide risk, hospitalization is very, very important. You have to, must do it. If not acceptable, what are the frequent intensive outpatient treatment with pharmacological and psychotherapeutic intervention? Utilization of the patient support system, family members, friends, our core worker is essential. So any hostler is there, you must contact that hostler also. Caregiver are to be educated about the high risk management. So this is a very important issue. You must explore it, and it is very easily available. So that is very, very important. In mostly medical college, they have got the contact number of the parents, and so this is very, very important. Action plan can be formed with caregivers collaboration in case the patient becomes acutely suicidal. So this is very, very important for this prevention. Another strategy is formulating a crisis plan. In our JMCH, we have a crisis intervention clinic type that. So crisis plan is very, very important. The particular teamwork is there. So they contain details like steps for the patient to follow when they are suicidal. Pharmacological intervention, behavioral intervention, contacticity others and mental is to be mentioned. So detailed plan can be there. What will we do next? And so all the contact numbers, all the chains of that should be there. How they will report into a local emergency department. Give the patient a written algorithm to follow during times of increased distress. So patient knows what will do that, which number he has to report. So this is all very, very important for the prevention strategies. Now I just conclude. Medical professionals are not immune to mental health problems. Stigma delays consultation and early intervention. I'm already talking about stigma. Stigma is very, very important. Still there. So many research is there. Increases probability of negative outcome like suicide, mental screening, awareness, destigmatization, systemic and worldwide. So suicide prevention is possible. I will request everyone who is on the seat, I will just call, we take a pledge, whoever sitting here, say no to suicide. Say no to suicide. Say no to suicide. So this is very, very important. So we are not going to commit any suicide throughout your life. We can live our life for other people. So this is very well. So we say no to suicide. So I'm all this presentation to Dr. Archana Sharma, and very gold medalist doctor who laid his life for this. And you all know this. When I was preparing this slide, I was just thinking about that great doctor, Dr. Archana Sharma. I pay tribute to that late Dr. Archana Sharma. Thank you. Save the savior. Thank you very much.
Thank you, Dr. Gurundarpal Singh. A very appropriate lecture and a very appropriate topic of the need of the day. So the suicide is very common in our medical profession and it is very much underestimated. And most of the time we hesitate to probe the case. So we should look into the matter carefully as a medical professional, as a psychiatrist, so that we can try to prevent these cases in future. So now the house is open for the discussion.
I'll just like to make two comments here. The first is that Indian Psychiatric Society has also started the suicide helpline for general public, which can be utilized by medical professionals also. So that's important to understand what IPS is doing on this behalf, because we here at PUNJAB, we're not talking about starting a separate helpline by the local branches, because it has legal implications and there are other implications. So IPS has started, we all need to promote that kind of a helpline so that anybody who is in need can seek help from the IPS suicide helpline. And the other issue with regard to the prevention or the management of suicidal behavior comes with the most important aspect is peer support. I think we need to understand the peer support is a very, very big thing which can be utilized by us as psychiatrists. When we train other residents or other medical students how to identify distress in your peers, and then you tell, either you alert the appropriate authority that I think he or she is under stress, so he or she requires evaluation, or the peers promotes the colleague to come and seek help, or they monitor somebody who has been reported to have some kind of suicidal behavior. For example, somebody comes with suicidal ideation to our OPD. So we make a peer network for them, that the peers are supervising them. He's not allowed to stay alone, because students who are staying in the hostel cannot be relied. Just when we talk about suicide prevention, all these strategies may fall flat until we use the peer support.
Very nice, sir. Yeah, absolutely right.
Any other question?
Medical professionals versus general population. Is there any fragmentation? Which medical professions are more prone than others? Is there any fragmentation in different specialties or different?
Yeah, as I told, 3 departments are at the top. One is the anesthesia, another is medicine, then the psychiatry.
Then the
psychiatry.
Psychiatry.
Surgeons are better.
So-
what I'm taking, these are from the studies or like that.
And as you told, prevention is better than cure. But I think in this field, it's not better than cure. Prevention is the only cure.
Yes, sir.
One part. Dusre, all these strategies we elaborate, they are more for palliative approach. Unless we go to the curative approach, not just palliative, probably nothing will come out. And we have to intervene at levels in which none of these problems have manifested and improve not only cognitive intelligence as we do in medical career, we improve their emotional intelligence, we improve their spiritual intelligence. So that IQ, EQ, SQ, we call it. IQ is intelligence quotient, EQ is emotional quotient, and SQ is spiritual quotient. At least emotional quotient, if somebody is very high, he will not fall trap to these things. And we have to improve the EQ, at least EQ of all medical profession from day one, before they have all the manifestations of diseases and take palliative measures. That's personally I feel.
Right. Thank you, sir.
If there is no more question, then we are concluding the session. Thank you. Thank you.
Thank you, Dr. Gurvinder Pal and the chairpersons. Now I'll request the chairpersons to felicitate Dr. Gurvinder Pal. I'll request Dr. Gulbahar to felicitate Dr. Chopra. Dr. Gulbahar to felicitate Dr. Chopra. So happy birthday, sir. Hanji, sir. Thank you. Jay. Dr. Aparajita to felicitate Dr. Dipali Gul. And Dr. Gurvinder Pal to felicitate Dr. Asim Mehra. Now we move to the last final session of the day, which is the free paper session. The chairpersons for the same are Dr. Gurmeet Kaur, who is present here in the hall, and Dr. Swapanjit Sahu, who is present online. And in total we had 11 free papers and posters. So there was 7 free papers and posters presented online in the morning, and now we have the physical paper presentation, and we have 4 presenters here for the session. Dr. Swapanjit Sahu is already available online. So I will now request Dr. Gurmeet Kaur to come onto the dais. I'll just check the 4 presenters here. Yeah. Dr. Gaganneet Sekho, is she there? Yeah, thank you. Dr. Ishan Prakash Garg, yeah. Dr. Ritu Diman, yeah. And Dr. Sandeep Bangar, yeah. So over to the chairpersons. So the sequence is the same: the Gaganneet, Ishan, Ritu, and Sandeep. Okay, yeah.
Very good afternoon. So I think this is the last session. You might be very tired. So don't worry, patience only for 40 minutes. Again, I'm saying the same thing now, like we already have gone through pandemic and okay. So after the pandemic, still it is going on. We are receiving, you might be agree with me, we are receiving more and more patients having depressive disorder and even with anxiety disorder. So currently in our setup, and I think in your setup also, we are receiving calls from the other wards, from the other facilities like medicine and like surgical wards. So having chronic illness and having depressive symptoms or anxiety symptoms. So my students, they are also presenting papers on these issues. And I think for students, only 5 minutes for presentation and 3 minutes for discussion. Thank you. And first presentation is Gagni Sekho. Topic is assessment of depressive symptoms in hospitalized cancer patients. Over to Gagni.
A very good afternoon, everyone. Myself, Dr. Gagneet Sekho, Junior Resident, GGS MCH Freeport. My topic of discussion is assessment of depressive symptoms in hospitalized cancer patients. Depression is a common. A cancer diagnosis is life-changing and is a source of considerable psychological and emotional stress. Sadness may be a normal response to a cancer diagnosis. However, stress beyond the coping mechanisms of patients may result in major depressive symptoms in cancer patients. Depression reduces patients' quality of life, negatively impacts compliance with medical treatment, and carries an elevated risk of mortality. In present study, Hamilton Depression Rating Scale was used to assess the depressive symptoms in cancer patients. The aim and objective of this study is to evaluate the severity of depressive symptoms in hospitalized cancer patients. A total of 30 cancer patients who were admitted in radiotherapy ward in the month of February 2022 in a tertiary care hospital were enrolled for the study. A written and informed consent for the study was taken beforehand, and severity of the depressive symptoms were assessed using Hamdi scale. Fisher exact test and NOVA was used for statistical analysis. In the results, it was observed that out of 30 cases, 26.7% cases had depressive symptoms in very severe category of Hamdi scale, while 6 had symptoms in severe category. 30% cases had depressive symptoms of moderate category, while 16.7 presented with mild depressive categories, and only 6.7% no depressive symptoms were observed. In this figure, we shows that the type of treatment, extent of disease, that is presence of metastasis or no metastasis, and time since diagnosis, that is old diagnosis or newly diagnosed cases, showed significant association with the severity of depressive symptoms. 62.5% patients with very severe depressive symptoms were on radiotherapy, while all patients who had no depressive symptoms were undergoing chemotherapy. Similarly, patients who did not present with depressive symptoms did not have metastasis, while 87.5% with severe depression symptoms had metastasis. In our study, it was found that patients with old diagnosis undergoing radiotherapy on palliative care and with metastatic disease were observed to have severe depressive symptoms. In a study done by Lidit et al. And Mazumdar et al. Also showed that the advanced stage of cancer was associated with severe depression, while Pettington et al. Showed no association between depression and clinical variables like histological grade, extension of disease, nodal stage, and treatment in breast cancer patients, but found a significant association with these variables in patients with Hodgkin's and non-Hodgkin's lymphoma. In India, a study conducted by Sharma et al. In 100 cancer patients showed maximum prevalence and severity of depression was seen in patients having head and neck malignancy. Meanwhile, in our study, no association was found with the type of cancer. Koenig et al. In this study showed that depression in cancer patients increases with increased length of hospital stay and resource use, increased health expenditure. In present study, it was observed that patients who had more average time of hospitalization suffered severe or very severe depression, although it wasn't statistically significant, which could be due to small sample size. No significant association was found when participants were compared based on socio-demographic variables like age, sex, marital status, religion, and income. Conclusion, study suggests that socio-demographic variables might have lesser role in etiology of and severity of depression in cancer patients as opposed to general population. Disease-related variables like extent of disease further area of research in association to the severity of depressive symptoms for early diagnosis and prompt treatment in such cases. Various limitations were seen in this study, that this being a cross-sectional study which could only provide some clues rather than any causal relationship. The sample size of this study was relatively small. Confounding intervention of symptoms such as weight loss, loss of appetite, insomnia, psychomotor retardation, fatigue, resulting from cancer itself or the treatment of cancer could lead to overestimation of presence of depressive symptoms. Absence of a clinical structural interview with patients, which is needed for probable diagnosis of depression according to HDRS, wasn't present. Thank you very much.
Okay, good presentation. So open for discussion.
Yeah, may I? And congratulations, doctor. And I would like to ask one question, because as you have already said that there are various confounding variables which are itself in the HDRS, like fatigue, weight loss, and which can also be very well present in patients with cancer or those with terminal illness. So I think there should be any other good instrument which you could have used, like BDI, which could assess the depressive cognizance in a more better way. Second question is, in what category of cancer patient, in which group of cancer patient like head and neck or pancreatic, you found greater severity of depressive symptoms?
Thank you, sir, for the question. So yes, there were other scales which could be a better instrument for this type of diagnosis, like PQI. But through my when I was trying to find a scale for this, I found that PQI was according to DSM-4 criteria, which we do not follow anymore. For that could be an instrument that I could not use. And about the type of cancers, the majority of cancers which I found in our radiotherapy ward were of breast cancer and non-Hodgkin's lymphoma patients, which had more severity of depression, but no significant association was found. So because that could be probably due to the small sample size. If it was a bigger sample size, I think that values would have been more significant.
Okay, good. Thank you.
Thank you. Anyone from the house? Any student? I think no one. All are satisfied. So we'll go to the second. Okay, beta. Thank you, Dr. CHANDIGARH. So topic of his paper is assessment of anxiety symptoms among opioid substance users.
Dr. Shan.
Good afternoon, everyone. Myself, Dr. Ishan, second year junior resident from GGS Medical College, Freeport. My topic for poster presentation is assessment of anxiety symptoms among opiate substance abusers. Introduction. Opiates are a group of substances that act on opiate receptors, generally used to control pain and which have significant abuse potential. A large number of people who are abusing opiates have other psychiatric comorbidity also. The relationship between mood and anxiety disorders and opiate use, they can emerge in one or more non-exclusive ways. Behavioral and neuroplastic changes arising out of chronic use of substance, they can result in mood and anxiety disorders. And vice versa, mood and anxiety disorders, they can also lead to use of opiates as a self-medication to relieve the symptoms. Aims and objectives of my study are to assess the severity of anxiety symptoms among opiate substance abusers. Methodology is a total of 30 patients who were admitted in de-addiction ward in tertiary care hospital. During the month of February and March, they were enrolled for the study. A written informed consent for the study was taken beforehand. Anxiety symptoms were assessed using HAM-A scale, and Fisher exact test and ANOVA was used for the statistical analysis. In my study results, which were came out of 30 cases, around 50% cases they had no anxiety symptoms, while 6.7 cases they had anxiety symptoms in severe category, and same 16.7% cases had anxiety symptoms in moderate category, while 26.7% cases they presented with anxiety symptoms in mild category. On comparing the severity of anxiety symptoms, it was found that in patients with heroin use and using injectable method, they had significant more anxiety symptoms than patients with multiple drug abuse and those consuming drugs in paper or oral method. No significant association was seen with age group and sex. In present study, maximum opiate users, they were males. Similar findings have been reported in different studies. In present study, mean age of the population is 26.9 with standard deviation 2.6. Similar results were obtained by Sharma et al., who found the mean age of the study population was found to be 29 years with a standard deviation of 6.24 years. In present study, out of 30 cases, 50% cases, they had no anxiety symptoms, while 6.7 had anxiety symptoms in severe category, and 16.7 had anxiety symptoms in moderate category, while 26.7, they had anxiety symptoms in mild category. Sharma et al. In their study, they also found that more than 50% of the participants, they had anxiety, and in majority among them, the anxiety was mild in severity, which was similar to the present study. On comparing severity of anxiety symptoms, it was found that in patients with heroin use and using injectable, they had significant more anxiety symptoms than patients with multiple drug abuse and those consuming drugs in paper or oral method. Conclusion is substance use disorders, they are associated with high levels of anxiety, and anxiety disorders and substance use disorder, they co-occur at greater rates than would be expected by chance alone. Thank you.
Okay, good presentation. Like paper is open for discussion. Anyone from the house?
Yeah, good presentation. I would like to ask one question. What was the timing of assessment of the anxiety symptoms? Because if it was any type of withdrawal symptoms, then they might report more anxiety symptoms.
So first of all, they were assessed during their admission period. And after when they follow up in OPD, during that time also we assess these anxiety symptoms.
During admission.
And there was, so basically we had to follow the patient during their.
At what time you have taken the patient? During the admission?
First of all, during their admission tenure for around 10 days, we assess the patient at the time of admission.
Any other thing?
Indoor patients we have kiya tha basically.
Only indoor patients?
Yes, ma'am.
Follow up after how many days?
Ma'am, after 5 days after discharge from the addiction.
Assessing anxiety too close to the inpatient
or during the inpatient, this patient will be actually having withdrawal features or craving, which will be thought of as anxiety symptoms. So the assessment time frame here is possibly not appropriate. That is being pointed out. So ideally, patients who have been abstinent for a couple of months, if you are assessing them for anxiety symptoms, it can be clearly said that the anxiety disorder or the anxiety symptoms are independent of the so-called substance use. That's where the study needs to look at the timing of assessment. Okay. Yeah.
Okay.
Next presentation.
Okay, next presentation. Dr. Ritu. So topic of paper is to assess the anxiety symptoms again in cancer patients.
Good afternoon, everyone. I'm Dr. Ritu, and the topic of my study is to assess the anxiety symptoms in cancer patients. Anxiety is one of the most common reasons for psychiatric consultation in terminally ill cancer patients and has been linked to lower levels of quality of life, increased level of insomnia, decreased trust in physicians, and poor treatment compliance. Anxiety can negatively impact recovery from medical procedures and may even impact survival time in cancer patients. Anxiety and distress may affect a patient's ability to cope with the cancer diagnosis or treatment. Even mild anxiety can affect the quality of life of cancer patients and their families and may need to be treated. This in turn may result in increasing stress and feeling of despair. Routine screening for anxiety is internationally recommended as a necessary standard for good cancer care. People with cancer, as well as their friends and family, can feel distress about these things at any time after cancer diagnosis, and even many years after the cancer is treated. Aims and objectives to assess the anxiety levels in cancer patients. A total of 30 cancer patients who were admitted in cancer ward in the month of February 2022 were enrolled for study. A written informed consent for the study was taken beforehand. Anxiety symptoms were assessed using Hamilton Anxiety Rating Scale. It is a 14-point scale. Fisher exact test and ANOVA was used for statistical analysis. Results: out of the 30 patients, 16, that is 53.3% patients, were found to have mild anxiety symptoms on HAM-A scale. 6, that is 20%, were in moderate category. 6, that is 20%, were in severe category. And 2, 6.6 were having no anxiety symptoms. Male patients, total of 18, that is 60%, were having mild or no anxiety symptoms, while female patients, that is 40%, were found to experience moderate and severe anxiety symptoms. On comparing the grades of anxiety in patients, it was seen that anxiety symptoms were significantly more in females. Those were on radiotherapy and chemotherapy. No significant findings were observed when patients were compared on the basis of socio-demographic variables, including age, sex, and religion. And the mean age in the study was 54.5. Discussion. In a study by Pandey et al., 60% cancer patients had mild anxiety, 38% has mild to moderate anxiety, and 2% had moderate to severe anxiety, which was similar to the results obtained in the present study, where 16, that is 53.3 patients, 3% patients were found to have mild anxiety symptoms on HAM-A scale. 6, that is 20%, were in the moderate category. In the present study, patients on chemotherapy, that 61.9% has mild anxiety, 20% in radiotherapy had mild anxiety, while on palliative care, 50% cases have mild anxiety. It was observed that patients on palliative care had no anxiety or less anxiety as compared to other two treatment groups. In a study by Pandey et al., in patients undergoing chemotherapy, 66.7% had mild anxiety. Among those on radiotherapy, 53.3% had mild anxiety, and among those on combined chemotherapy and radiotherapy, 60% has mild to moderate anxiety. The result of the present study showed significant association of treatment type, and sex with anxiety severity. Similar results were obtained by Sahithya et al. Also showed that females have more severe anxiety. In their study, patients who were on radiotherapy and chemotherapy had more severe anxiety, but it was not statistically significant. However, in the present study, the result was significant. Limitations of the study: as this is a cross-sectional study, so it can only provide clues and cannot provide the exact causal relationship. The sample size is small in this study. As a result, it is difficult to determine if a particular outcome is true finding. Conclusion: this study was conducted with the aim to find out prevalence of anxiety symptoms in patients undergoing cancer treatment. We found that female patients and patients undergoing chemotherapy and radiotherapy have more prominent anxiety symptoms than patients on palliative care. We believe that good cancer care needs continuous screening for anxiety and depression. It is paramount that after the diagnosis of clinically significant important psychological disorders, proper treatment interventions must be performed so that their quality of life gets improved. Thank you.
Okay, thank you. Good presentation. So any questions from house? From student side? So next. Okay, thank you, Bata.
Thank you.
So next, Dr. Sandeep. So topic of paper is assessment of depressive symptoms among opioid abusers.
Dr. Sandeep.
Good afternoon, everyone. Myself, Dr. Sandeep Bangar, Junior Resident, GGS-MCH Freeport. My topic of discussion is assessment of depressive symptoms among opioid substance abusers. Introduction. Depressive disorders are common among the opioid abusers with rates ranging from 14% to 55%. A significant challenge in the study of depression in opioid user is that the opioid may induce symptoms that are difficult to distinguish from the symptoms of primary mood disorder. Depressive symptoms may be attributable to an opioid toxic effects, drug withdrawal, or short-term life crisis. Aims and objectives to assess the severity of depressive symptoms among opioid substance abusers. Methodology: a total of 30 patients who were admitted in de-addiction ward in tertiary care hospital in the month of March 2022 were enrolled for the study. A written informed consent for the study was taken beforehand. Depressive symptoms were assessed among using HAM-D scale, Fisher extract test, and ANOVA was used for statistical analysis. Result: out of 30 patients, 9 cases, that is 30% cases have depressive symptoms in mild category, and 7 cases, that is 23.3% cases have degree of depression. Had severe depressive symptoms, and 12 cases appear normal during the study. Then discussion. The impact of depression on opioid users is extensive. Comorbid depression may be associated with premature dropout from treatment, and it has been associated with poorer prognosis after drug treatment. Comorbid depression may serve as an important trigger for high-risk injection practices, continued drug use, or drug relapse. Situations involving negative mood states are among the most frequently cited precipitants of relapse among several types of addictive substances. Substance abuse by psychiatric patient may be motivated by efforts to alleviate symptoms of primary psychiatric disorder. Conversely, mood disorder may be induced by substance use. Thus, in present study, out of 30 patients, 9 cases, that is 30%, presented with depressive symptoms in mild category. 7 cases had depressive symptoms in moderate category, while 2, that is 6.7% cases had depressive symptoms in severe category, and 12 cases, that is 40% cases, were having no depressive symptoms. A study conducted by Sharma et al. In 2013 in northern eastern state has showed that 82% patients were having depression, out of which 21% had mild, 48% had moderate, and 30% had severe depression. Arora and Kaur had found a prevalence of 29% in the participants having substance-induced depression. On comparing severity of depressive symptoms with other parameters, it was observed that in patients using heroin use and using injectable had significantly more depressive symptoms than patients with multiple drug abuse and those consuming drugs on paper, that is inhalational route or oral. Lifetime major depression in treated heroin users has ranged from 38 to 54%, which is in range of present study. Conclusion, depression complicates the treatment of illicit drug use disorder and is associated with higher rate of relapse following treatment and poorer outcome in terms of drug use. Furthermore, there are a number of factors that has been independently associated with drug use and depression, which presumably would be of increased concern in individual with comorbid substance use disorder and depression. Thank you.
Okay, good presentation. So any question from the house?
Yeah, good presentation. I would like to ask one question. In how many patients you had found any past history of depression? And what, do they have more severity at the time of assessment?
So there was no patient that had past history of any depression in my study.
Okay, if there is no question from the house, then I should conclude. So, okay, beta. So again, at the end of this session, I am really from my heart, I am thankful to Dr. Sidhu and the whole organizing team, as I have learned so many new things and very good and wonderful experience, learning experience. Thank you. Again, thank you.
Thank you. Thank you, the organizers, for conducting the very good concepts, the academic session. Thank you all.
Thank you, chairpersons. I'll now request Dr. Gulbar Sidhu to felicitate the chairperson, Dr. Gurmeet Kaur. And with this, we are coming to the end of the scientific sessions, and we'll be just starting with the valedictory session now. So for the valedictory session, I invite Dr. Dipali Gul, the president of PUNJAB, Dr. Gulbar Sidhu, the vice president, and myself. We are on the dais for anybody to make any comments about the program and anything. So, yeah. Thank you everyone for joining us here. And as I said, that we started the concept event this time after a gap of 2 years, and I'm sure that there will be a lot of loopholes in the way we organized the program, but the primary aim was to get back to track. And as far as my information is there, we had about 250 registration for this conference, which I think is a good number. And considering this is a state branch conference, and I thank all the delegates, all the speakers and chairpersons for their participation and helping us to conduct this program. Special thanks to all the speakers who spared their time to come here and make the presentation. So now I open the forum for any kind of feedback from the participants. Yeah, Dr. Gurvinder.
I congratulate Dr. Dipali, Dr. Gulbar, Dr. Sandeep Grover for such a very nice, it was more of academic very activity. So it was more academic feast. So very well organized. I've seen, I repeatedly asked Dr. Gulbar that you are not getting nervous because organizing conference is a very, very tough job. So I congratulate them and hope that this standard will maintain in future also. Thank you, sir. Congratulations, sir.
Thank you. Yeah. Anybody else? Anyone else wants to make a comment? No. So just for the information of others, the next PUNJAB and the PG development program of the Punjab and Chandigarh state branch will be held in Ludhiana. The PG development program will be possibly held in the month of February, March 2023. In the month of August, September 2022, and the PUNJAB will be held in the month of February, March 2023. So with this, we are coming to the end of this PUNJAB. So I'll request the so-called I'll request the organizing secretary and also the vice president of PUNJAB to make his remarks, and then ask the president to make her remarks.
Thank you everyone for coming here. And yes, nobody is perfect. We are not perfect. And the next time if given an opportunity, we'll try and make it even better. And many thanks for the support given by Dr. Sandeep Grover. He is my man Friday for every crisis. Thank you, sir. And it's all happened because of you. Thank
you.
Thank you everyone for making this event a successful. Although shortcomings are always there, but we'll try to fulfill them. We'll make a better one with all your cooperation. Thank you.
With this, we close the conference and hope to see you in the PGP development program in Ludhiana in the month of August, September. Thank you, everyone. प्रेजेंटेशन सारी कहाँ है? प्रेजेंटेशन फोल्डर में डाली हुई है ना, मुझे दे दो और फिर यहाँ से सारी डिलीट कर दो.